Hello, everyone. My name is Vinay Mandagari, and I'm going to be talking you through the Medic Sleep webinar. Welcome to the webinar. So I am a fourth year medical student with the University of Bristol, and I'm one of a team of people who are interested in sleep. So today's webinar is going to cover the whole day, and we're going to be teaching you a little bit about how to take a sleep history, how to manage insomnia, advising some of your patients, a little bit of sleep disorders, and also some really important knowledge on how to survive night shifts as a junior doctor. So the Medic Sleep webinar is part of the virtual elective scheme at Medics.Academy, and we've essentially joined it to learn a little bit more about medical education and technology. A lot of you are going to be medical students. Some of you are going to be work experience students looking for some virtual work experience. Med students, you're going to learn a lot that isn't really covered in the normal undergraduate curriculum, but is really, really important for your future work as doctors. And for work experience students, there is going to be some stuff that might be a little bit over your head, but there's a huge amount to learn. And sleep, as I said before, is really, really under-taught at medical school. So it'll put you in good stead for when you are training up to be a doctor. So just an introduction, why exactly did we choose sleep as our subject? The four of us who are involved in our virtual elective, we all have quite different interests. I'm interested in psychiatry. We have a few interested in general practice and someone interested in dermatology. And we generally found that we wanted a theme that would bind us all together. And we found that sleep is something that affects all areas of health. So we thought that should be the focus of our webinar. So we did a little bit of research and we wanted to find out, well, how common are sleep problems in the general public? And we were really, really surprised. We found that around 20 to 40% of all GP consultations were sleep related. That's almost a third of our patients have sleep problems. And then we thought, well, in our regular training, how confident are we? How much knowledge do we have that we can deal with patients who have sleep problems? We asked some of our followers on Twitter, and these are the sorts of answers they gave us. They said, well, we've had one specific lecture on sleep. I think we had a lecture on brainwaves and there was some physiology there, but I didn't quite understand it. And we had someone who actually said that, well, I have a sleeping disorder and I often find myself having to discuss the basic science behind sleep, the basic stuff about sleep disorder to my peers and colleagues, because people aren't willing to admit that we aren't trained in sleep issues. So clearly there's a bit of a deficit in our curriculum. But how confident are you guys in answering some of those questions? How confident would you be if you had a patient in front of you saying, I have trouble sleeping? We asked our Facebook group, and amazingly, we found that the vast, vast majority of you said you had zero confidence in dealing with a patient who says, I have trouble sleeping. So clearly there's a bit of a problem, and clearly we need to learn a little bit more, because we're doing a great disservice to around a third of our patients. So we also chose sleep because it affects all areas of health. It doesn't matter if you want to become an endocrinologist, a GP, a respiratory doctor, a surgeon, a dermatologist, a psychiatrist, or a pediatrician, all of your patients will sleep. And most of your patients, whichever conditions that they have, it'll probably affect their sleep as well. So it's really important for you to know as future doctors, and it's really important for you to know if you work in the field of healthcare in general. So if you want to be a clinical psychologist, if you want to be a nurse, if you want to be a physiotherapist, because it affects their health massively, as you'll find out for the rest of the day. So if there's one take-home message for you to take away from this webinar, it's to ask your patients about sleep. Embed it in your history taking so that they don't feel as though they're holding back on one of their biggest problems in their life. So a little bit about engaging with this webinar. It's going to be it's a whole day thing. So we are hoping to end around 4 in the afternoon, but there are going to be some breaks. It's really, really important that you join our Slack channel. Slack is essentially like a chat function. We're going to be posting some multiple choice questions, some polls. It's also really good for you to get networking. Some of you are work experience students. It'll be great for you to meet some medical students, especially if they're at the medical schools that you're applying for. Some of you are medical students from abroad. It will be great if you got chatting to some UK doctors and UK medical students to find out a little bit more about the system over here. And of course, if you have any questions about any of the topics that are raised here, please put it on the Slack. We do have a Q&A panel at the end of the day at 3 with our experts. So that's the perfect time for you to ask some of those burning questions you have about sleep. So the QR code is just there on the right. We've also posted it on our Facebook, our Twitter, our Instagram for you to join the Slack channel and engage with today's webinar. So in terms of using the Slack, introduce yourself for now. Tell us what you do, tell us what grade you are. And a really important question is, why do you like sleep? And I've asked that question. We've got a few responses so far. Someone said they're worried about how much sleep they'll get as a doctor. Very important question. And we have a session on night shifts and work as a junior doctor. Someone's interested in sleep disorders. So I'm going to be running the session on sleep disorders, asking patients about sleep. Really important. Caitlin's going to be running through that, and we're going to have a live sleep consultation. And yeah, people just generally don't know about sleep, which is not surprising. We don't get taught it, but here's our opportunity. Just wanted to show you this. We have had a lot of people sign up to our Medics sleep webinar. I just wanted to show you that we have actually had people sign up from all across the UK and all across the world. So if we have a look at the UK, we have people from Edinburgh, Glasgow, Aberdeen, all the way down to Brighton and Plymouth, even places as exotic as Cardiff. And then from all over the world, we have people from Eastern Europe, people have signed up from Nigeria, Egypt, someone from Canada's here for some reason, India, Pakistan, Philippines, Indonesia. Incredible stuff. All people who are interested to learn more about sleep. So let's get back to the presentation. So the program for today. So once I've stopped talking, we will have Dmitry Gavrilov, who is a senior clinical psychologist at Oxford and a tutor in sleep medicine at the university, talking about why we sleep and why you should care. Caitlin, our medical student from Hull, York, is going to be talking about a little bit about insomnia. And then we have a live sleep consultation with Dr. Ashish Bhatia, GP in Bristol, with a patient. Rita from Plovdiv, Bulgaria, a final year medical student, is going to be talking about sleep problem in kids. And then to end off our morning session, we have Dr. Mittal Mysooria, a GP ST1 trainee, talking about surviving night shifts. Really important topic. We then have a bit of a lunch break, and then I'm going to be going through quite a heavy topic of sleep disorders. And there's going to be a bit of interaction on the Slack channel. We have a break for you to network with some of the people that have joined our Slack and our program. And then we have some really interesting stuff from Sara Imani, who's a final year medical student at Leeds, talking about the relationship between sleep and skin. And to end off, Dr. Soma, a registrar in dermatology in London, talking about the truth about beauty sleep. To round off today's webinar, we will have a panel with all of our experts, plus Dr. Jane Hicks, who is a consultant psychiatrist and an expert in sleep, to answer your questions. And we'll have the medical student team back again to talk about our journey to medical school for all of you work experience students. So I've asked, so if you are on social media, please start following the conversation on Twitter, use the hashtag MedicSleep, tag us, we are at MedicSleep. It'd be great to get some conversation on different social media. And I'd just like to end my final introduction with one of my favorite quotations from Shakespeare's Macbeth. And it says that sleep, and it basically sums up why I love sleep. Sleep that knits up the ravelled sleeve of care, the death of each day's life, sore labour's bath, balm of hurt minds, great nature's second course, chief nourisher in life's feast. Great stuff. I am going to hand over to Dr. Dmitry Gavrilov now, who's going to be talking a little bit about why we sleep and why you should care. So, Dr. Gavrilov, over to you.
Hi there, everyone. Thanks very much indeed, Vinay. It's a real pleasure to be here and to be talking to you about sleep. I just want to, just off the back of what's just been said, just completely and utterly kind of reinforce that message that sleep is super important, and rather unfortunately and cruelly in a kind of an ironic sense, it's underappreciated, I think, in terms of its importance in medical education broadly. So this is a great opportunity to kind of supplement what you might get. And I'm going to talk to you a bit about the basics. It's only half an hour, so this is not enough time to even really get down beneath the surface, but we'll do our best. So I'm Dmitry Gavrilov. I'm a clinical psychologist by training, but a specialist in sleep medicine. And I work split between my time in the NHS, my time at the University of Oxford, where I lecture in sleep medicine. And we'll start by just acknowledging that some of the slides I've got from colleagues, fantastic group of colleagues with whom I work at Oxford. And we'll talk about sleep in the context of the kind of the natural world. So sleep is something that we all do. Every single one of you will sleep. And as Vinay very aptly said earlier, all of our patients will sleep. Every single patient we see will sleep, or will struggle with their sleep, which is probably why we might be seeing them. But sleep is ubiquitous, right? So it's something that all humans do, but it's certainly something that all of our mammalian cousins do. And we can see from the spread there that actually it can vary hugely in terms of how it happens and how long it happens for, the way in which it happens. You've got a giraffe there down at perhaps only 2 hours sleep that sleeps standing up, and you've got macaques there in the trees that sleep precariously on branches that do it for significantly longer. You've got that ubiquitous 8 hours that's touted a lot for humans, and the dolphin above him that sleeps for longer, but does so with only half of its brain at a time. It has something called hemispheric sleep that it's able to do, allowing it to come to the surface for oxygen. And cute bunnies that sleep for a little bit longer, tigers sleep for a little bit longer. But what we can see here is it doesn't seem to really matter what your brain to body ratio is like, whether you're a predator, whether you're a herbivore, whether you fly, whatever it is. We all have different sleep needs, and we all do things slightly differently, albeit in the kind of, this is sleep in a mammalian sense. But most complex organisms sleep. And if we think about even kind of less complex organisms, plants, and actually many bacteria exhibit these distinct differences in terms of nighttime and daytime behavior. And this is because we've evolved on a planet that spins at a particular rate, and we have this day-night difference. And we've learned to, or we've evolved to do things differently in each of those periods. But the inference here is really important. The inference here is that sleep likely evolved or started to evolve a long time ago, before this evolutionary branching started to happen. And if we think about where we are now, we're a long way down that evolutionary road. Sleep is very important to us. It's a fundamental physiological element of our experience, but it's also something that is evolutionarily costly. While we sleep, we don't do anything. We're inactive. We're unproductive. We don't go out foraging, hunting, building things. We don't socialize with each other, and we don't reproduce. So the kind of inference there is also that we're subject to predation during this time. We're quite vulnerable as we lie there inert. And it must therefore be very, very important for us to sleep. It must be something that conveys some sort of evolutionary advantage for us to do so. And so that, I mean, this is just to kind of really reinforce just how important sleep is. Of course, no one who's ever experienced a sleepless night, who's woken up groggy the day after they've gone out late, or they've got an exam the next day and they haven't felt they've got enough sleep, no one will sort of be unable to appreciate just how important sleep is. Of course, we appreciate it, but from a physiological perspective, it is foundational and crucial. And there's a great book came out, I think, last year by one of our colleagues in the States, Professor Matthew Walker, who talks about why we sleep. I think the book is called Why We Sleep. And in fact, why we sleep is a great question, but there's no real single clear function for sleep. It's unlikely to be simply to rest and relax. Lying inert and not moving means you save calorifically a little bit, but it's not a huge amount. I mean, it's actually quite small, and that's unlikely to be the reason why we've evolved to sleep. It's actually probably more likely to serve a range of functions in humans, and these include things like anabolic and metabolic processes, that the build, the repair, the restore processes that go on in the body and brain across the night. They're also, sleep is associated with learning and memory consolidation. This is something that anyone who's ever stayed up all night cramming for an exam can appreciate the truth of, because the way we would do that best is if we learn during the day, or we allow ourselves time to consolidate that information across the night, and then we wake up the next morning and perform at our best. Staying awake all night to try and cram in all that information doesn't give us an opportunity to consolidate the memory, to consolidate the learning, and recall is thus impaired the next day. And we can show that experimentally. It has been shown experimentally an awful lot. But there's also an interesting element to the way in which sleep works in terms of something that we call the glymphatic system. But really this describes the disposal of, the dealing with metabolic waste in the central nervous system. And this is akin, I often say, to the maintenance crew, the janitors, the office cleaners coming in at the end of the day and removing those coffee mugs that have been left out all day, or emptying the waste paper baskets, such that the office is able to function optimally the next day. And where we see that happening in the brain at night, we see cerebrospinal fluid coming up into the brain, bathing the cortex and removing this metabolic waste. But this is something that is normal and natural, needs to be allowed to happen. And when sleep is impaired, when sleep's not happening in the way in which it's intended to happen, then these things aren't happening either. But also, sleep is crucial for emotion regulation. And we know that from the experimental research, but it's also something that we can all again, kind of touch base with in terms of our own experience. We know that when we don't sleep well, we struggle to manage our emotions, we struggle to manage our mood, and we know, as we'll get onto in a bit, that poor sleep, disturbed sleep, is strongly associated with a range of mental health problems, and it infers an increased risk of the development of many mental health problems. So when we talk about sleep, what does sleep look like? And many of you will have seen one of these before. This is called a hypnogram. And a hypnogram is just a diagram of the stages of sleep. Here we have sleep split, or we have three stages really of consciousness in human experience, if you like. One is wakefulness, and one is non-REM sleep, as we call it, NREM, stage 1, stage 2, and stage 3. And the third stage is REM sleep, or rapid eye movement sleep. And these are all distinct physiological states of consciousness. And what we see across the night is that we start in a period of wakefulness, and we get drowsy. We eventually start to nod our heads and fall off to sleep. And if we're lying in bed, this probably isn't very obvious to us, but we transition into sleep. We go into very light sleep, initially. And that light sleep, that stage 1 sleep is very, very fragile. Any noises around us, any changes in the environment are likely to disturb us from that sleep. And then we go down into deeper sleep, stage 2 sleep. This is kind of the average sleep, if you like. It's the stage of sleep that we get the most of throughout the night. And then down even further into slow wave sleep, into deep sleep. So when your commercial device, your Fitbit or whatever it is that you're wearing, tells you you're not getting enough deep sleep, what I guess they're referring to is this stage of sleep here. Quite how accurate they can be, I'm not sure, but the point is that we get that deep sleep, that restorative deep sleep in the sort of first third of the night, and this cycling through stages you can see here happens. I mean, this is a generic representation, but probably happens in adults over about 90 minutes initially and might change across the course of the night. But essentially, we go down into deep sleep to begin with, up into lighter sleep, and we have these periods of rapid eye movement sleep that follow this initial cycle, and then down into deeper sleep again, up into lighter sleep, again, another period of REM. And so that period of REM typically follows that cycling through deeper sleep and up into lighter sleep. And then you may also get these brief periods of what we might call a nocturnal awakening or an arousal, when you come up into lighter sleep state or come into very light sleep or into wake, and you might sort of shuffle around in bed and perhaps, you know, fluff your pillow up a bit and then go back to sleep. And these things happen, you know, quite regularly throughout the night to good sleepers and to poor sleepers alike. They're not a sign of anything problematic. But in poor sleepers, very often they can become a prolonged period of awakening. So what we can see here is this actually increasingly synchronous brain activity throughout the stages as we get lower and deeper into sleep. And then into REM sleep, we get these very odd periods of what we call paradoxical sleep, REM sleep, we'll talk about in a bit, and these brief nocturnal awakenings which might happen. But slow wave sleep, that deep sleep, happens during the first third of the night typically, and then there's much less, if any, in the last part of the night. And the second important thing to see is that we actually get more REM sleep as we move through the night. And this is why people, when they talk about remembering their dreams, often remember these periods, these narrative dreams. We dream throughout the night, but they experience these narrative dreams with emotional content during their periods of REM that probably happen in the morning just before they wake. So when we measure sleep, we typically measure through something called polysomnography, PSG, and we use PSG to look at discrete physiological parameters using various methods of investigation. So we've got EMG looking at muscle tone, EEG looking at brain activity, EOG looking at eye movement. You might combine that with ECG and oximetry to get a sense of exactly what's happening physiologically for the patient, and that gives us something like this. So here you have on the readouts here, you've got the eyes at the top, left eye and right eye in the green, and then you have the frontal, central, and occipital leads here, and you've got muscle tone at the bottom. And you can see that in wake, you have wake with eyes closed is characterized by this alpha activity, so alpha rhythm that's typically occurs at the occipital region, and we classify N1 stage 1 non-REM sleep with these slow rolling eye movements and what we call LAMP, or low amplitude mixed frequency waves. Stage 2, you get these things called K complexes and sleep spindles, and sleep spindles really are very interesting in so much as they are the brain, an area of the brain that's consolidating declarative memory, so learning during the day is what we think. And K complexes are really what we think the brain is when the brain is trying to essentially inhibit arousal or inhibit the potential arousal from external stimuli and also internal stimuli. But you get a very characteristic pattern there, which helps us to determine stage 2 sleep. And stage 3 sleep, you get these long, slow waves or delta waves that give us this very characteristic pattern of slow wave sleep. And in REM sleep, we get these rapid eye movements that are very characteristic of that particular stage of sleep, hence the name. But also you get activity in the EEG that's not unlike what you might see during wakefulness. So it's why it's often called paradoxical sleep. So this is something that's crucial to understand in terms of explaining sleep to patients or understanding it yourself. If we think about how sleep is regulated, we hark back to a model that was developed by Alexander Bovelli and colleagues in the 80s. And this is the two-process model of sleep. So on the x-axis here, we have the 24-hour period, 6 o'clock in the morning over here to 6 o'clock in the morning the next day, period of wakefulness and a period of sleep. And you have, or night and day, day and night. And on the y-axis here, you've got the first processes, which is what we call the homeostatic sleep drive, your drive to sleep, your sleepiness drive. And the sleepiness drive really is, it correlates with the buildup of adenosine, which is another metabolic byproduct that accumulates in the basal forebrain. And what we see is that over the course of the day, you become more and more sleepy. It's pretty straightforward, really. Wakefulness, extended periods of wakefulness lead to this buildup of sleep pressure, which eventually then dissipates across the period of sleep. So you fall asleep and the sleepiness goes. And it's a bit like a pressure cooker. Once you take off the valve, the steam is allowed to go. If you take a nap, for example, here in the middle of the day, as is done in many Mediterranean cultures, you may fall asleep a bit later because you may need a little bit longer for the sleep pressure to build. And that's overlaid with something we call the circadian rhythm. So this is the rhythm for alertness, typically, but it's something that governs all of our physiological function pretty much. And it's associated with this day-night differences, oscillation between light and dark, where arousal or wakefulness increases throughout the morning period. In most people tends to peak around midday, something like that, and then it starts to dissipate across the afternoon, such that you have a low period and the lowest period, probably about 2 hours before you wake up naturally, the circadian nadir. And you get this lovely sync where actually arousal and wakefulness, alertness is increased during the morning. You reach a peak, and this is overriding any sleepiness. And across the afternoon, gradually starts to dissipate. You start feeling more and more sleepy, and the sleepiness is getting more and more. You eventually fall asleep because the distance between these 2 points, you get something called a sleep gate. Your push to sleepiness is very high, your wakefulness is lower and lower, and you fall asleep. And so understanding that's very important. Coffee has a very interesting effect, or caffeine has a very interesting effect, in so much as it is an adenosine antagonist. And so what it does is it inhibits the brain's ability to essentially to recognize how tired it is, and it masks sleepiness. But of course, once it's metabolized, sleepiness is still there, and you kind of crash afterwards. So understanding the circadian piece to it's also really important. So when we talk about sleep, we must talk about circadian rhythms. So a circadian entrainment is done, or circadian rhythm, this day-night oscillation in physiology, is governed primarily by something, or entrained primarily by something we call, these are called Zeitgebers, time givers. And the primary one is light-dark, the light-dark cycle. So light comes in through the eye, hits the back of the eye. In the back of the eye, you have photosensitive retinal ganglion cells. These pick up the wavelength of light, transmit that information to the suprachiasmatic nuclei, which is your sort of master clock, your master biological clock, sitting just underneath the optic chiasm. And that information is then passed to really all the other clocks at an organ level throughout the body. And you have other cues too that help to entrain this rhythmicity, things like activity, mealtime, social cues, temperature, etc. And that helps to regulate this circadian clock, that circadian rhythm. The way I like to talk about it with patients is a bit like Big Ben. where this is a very crude analogy, but you might have someone who goes up every day and just makes sure the clock is set properly at the right time, sort of maybe pulls the clock back a bit. And of course, everyone all throughout the kingdom, all throughout the land, set their clock by, set their home clocks by what's going on in Big Ben. So the chap there kind of represents light. So if you get up at different times each day, light exposure happens at different times each day. What you end up doing is you end up kind of confusing the clock. But here's another kind of interesting illustration of what's going on in a circadian sense. You see that actually circadian rhythms, particularly during the sleep period, affect all sorts of physiological functions, not least core body temperature, which drops by about maybe even a couple of degrees throughout the night, and your core body temperature is at its lowest, as I say, about 2 hours before you get up naturally. Plasma cortisol changes, you've got core body, you've got blood pressure changes, melatonin changes throughout the night. So all these things are happening, and they happen normatively during this sleep period, which is again a function of both sleep pressure and being asleep, and the circadian process. This is the circadian process overlaying on top of it. So it's crucial, not just as this kind of, we tend to think of sleep as just this period of being inert, not really doing anything, but the body is very active, doing lots of different things during sleep. And I guess one of the questions I get asked quite a lot to kind of contextualize sleep for individuals is, Doctor, how much sleep should I be getting? That's a question I get clinically quite a lot, but it's also a question you get anecdotally talking to people at dinner. And what we can see is that sleep really changes across the lifespan. We start off, I've got a newborn, she's just over a week old, and she's sleeping an inordinate amount of time. She's sleeping perhaps 20 hours, something like that. She's just, I mean, well, probably more like 17. But the point is that she's sleeping a lot because that's normative for her in her age bracket. And as we get older and older and older, we sleep less and less and less. But what's important to understand is that at every stage of life, our normative sleep need, the amount of sleep that we probably need to function optimally, happens within a range, a normal distribution. And you may get people at the tails, but also most of us fall within that middle bracket. And so me in my age group, 40, probably around 7 to 9 hours, but that will depend on me. And so thinking about how much sleep I need, one of the things that my colleague, Professor Colin Espy here at the University of Oxford often says is, it's a bit like, people use this 8 hours, you should get 8 hours. It's a bit like thinking about a shoe size. If you were going to measure your size for shoes, what you wouldn't do is look on the internet and say, well, I'm a 40-year-old European man, and the average shoe size for a 40-year-old European man living in Oxford is a size 9, and go and buy a pair of size 9s. That would be a silly way of approaching shoe size. What you didn't do instead is you'd go into a shoe shop, have your feet measured, try on a couple of pairs of shoes and see how well they fit. And of course, that's more akin to our kind of finding out our sleep size. What we do is we see how much we need as individuals. And you may need a little bit more some nights than you do on other nights. But it's important to understand that sleep happens within range. Feedback there from right. Okay. So I think one of the other things that's really important to understand is how circadian phase changes across the lifespan. Very often in my pediatric clinic, I'll see young people, children and young people who rather unfortunately have been labeled kind of lazy teens or lazy adolescents by society, or by, frankly, sometimes by clinical professionals and by teachers, because there's a lack of understanding about the normative shift that happens in circadian phase, which is to say, when your clock sets your sleep period, your sleep-wake period, across the lifespan. And what we see in adolescence is we see that initially we start quite early. So this is your early chronotype. So people who go to sleep early wake up early. This is very late chronotype. People who go to sleep very late, you wake up very late. And you can see that actually the predisposition at a young age is to go to sleep relatively early and to wake up relatively early. And as you get through into adolescence, that then starts to change quite dramatically. And so you get people naturally going to sleep later and getting up later. Now, if you imagine the way that might affect someone who's trying to go to school, so if they have no choice because their body clock is getting later and later, and they're unable to get to sleep any earlier, if they're falling asleep at 3 in the morning, and yet they have to get up at 7 for school, and yet if we refer back to our slide earlier, and their sleep need at age, whatever it is, 15, is 9 hours, there's no way they can get 9 hours sleep from 3 in the morning to 7 o'clock. So they're invariably going to be sleep deprived, and they're invariably going to suffer, particularly during the morning period, because they're not only sleep deprived, but their circadian rhythm is also very low at that point. And so understanding this clinically is very, very important. And it's something that I'd recommend people look more into if they're interested. But we also see this steady advance again. We kind of revert, we come back into or rebound back into earlier chronotypes as older adults. So that's just an important kind of an aside, but it's all kind of important in contextualizing sleep. So the title of the talk was Why We Sleep and Why You Should Care. The fact that you're here listening to this at all implies that you have at least some degree of interest in sleep. And I think that's fantastic. This is something that we really want to encourage. But sleep problems, as Vinay's already said, are really, really common. I certainly see them an awful lot. We have huge waiting lists for our service, a lot of demand on our service because of the nature of the problem out in the community. But these are things that primary care physicians, nurses as well, see an awful lot of. Primarily, they might see sleep-related breathing disorders, things like obstructive sleep apnea and insomnia, both of which I'm sure you're going to hear about more later. But just to give you a kind of a sense of insomnia, the difficulty falling asleep, staying asleep, and perhaps waking too early, or some combination of the three, is happening regularly. So perhaps 3 days or more, and it's been happening for at least 3 months, with some sort of detrimental impact on daytime function. That level of kind of diagnostic criteria being met is probably being met by about 10% of the adult population of the UK, which is a staggering amount. And yet the treatments available to these patients are relatively few and far between. So they are very common, and they are markers for increased risks of several problems, not only physical health problems, things like hypertension, cardiovascular disease, obesity, various other metabolic problems, and mental health problems too, so depression, anxiety, even first episode psychosis, PTSD. These are, they are sleep problems set people up for the development of other problems and exacerbate problems that are there anyway. And so this isn't scaremongering. This isn't trying to make people worried about it. It's to say, surely we should be treating this stuff. Surely we should be caring for this part of our health too. Interestingly, you sort of hear people saying, I'll skip lunch today. I'll skip lunch today, or whatever it is. People think about sleep in a sort of similar way. I'll go to sleep a little bit later today, and even if they don't have a sleep problem, they might stay up a little bit longer to watch the end of a film or whatever it is. But all these things they're probably an unhelpful way of managing your sleep. Optimal sleep is about trying to help it take place in as natural a manner as possible. But sleep problems are also associated with most mental health problems. There's a great meta-analysis done by my friend and colleague Chiara Baglioni there, which found that actually, if you look at the diagnostic spread of psychiatric disorders, sleep problems are there in every single one of them pretty much. But the key thing here is that actually they're generally underdiagnosed, they're poorly understood and poorly managed clinically, and when they are managed, they're very often managed with unlicensed medications. People, not wishing to point fingers at all, but people saying, I'm not sure what to do, so I'll try, what a colleague has suggested, or I'll give this a go. And this all stems from the fact that we get really negligible training. It doesn't matter whether you're a clinical psychologist, whether you're a medic, whether you're a nurse, whether you're an allied health professional of some description, we all tend to get negligible training in the assessment, diagnosis, and treatment of sleep disorders. So if we think about, where they're happening, what they look like, they can happen everywhere. We think about sleep problems, very often people just think about insomnia, but insomnia is just one of many. It's the most common, but it's one of many sleep problems. We have sleep onset insomnia, where people may struggle to fall asleep. People may struggle to stay asleep, or they may have sleep-related movement disorders which keep them awake during periods of the night. They may wake up too early. They may experience sleep-disordered breathing. They may experience nightmares that happen during REM sleep. They may experience an advanced sleep phase, so their circadian or circadian rhythm disorder, circadian rhythm sleep-wake disorder, where their sleep is happening too early and they find themselves waking up too early. Might be a delayed sleep-wake phase, which is kind of the opposite, the teenage syndrome that I talked about earlier. It might be that they experience parasomnias, things like night terrors, confusional arousal, sleepwalking, that have become problematic. And there might be other things too, such as periodic limb movements in sleep, which are not allowing them to get the restorative sleep they need, and are actually inducing arousals, EEG arousals, throughout the night, which are resulting in insufficient sleep. But it might be something like restless leg syndrome, where the patient is unable to initiate sleep because of the discomfort in their legs. So there's a real range, a real spread of sleep problems. I haven't got much more time. Not that I'd love to keep talking to you about it, but I'm running out of time. So what I wanted to do was just to highlight a couple of books that might be helpful for people to look at. These are various books on various subjects. There's a fantastic pediatric sleep primer if you're interested in going into pediatrics on the left there. And there's a fantastic general overview book there, the Oxford Textbook of Sleep Disorders, on the right-hand side, which gives a really good overview of sleep medicine as a whole. But there are various other books there, particularly these ones at the top on insomnia. And the book there on the left but one, Overcoming Insomnia and Sleep Problems, is a relatively cheap book that you can buy for people, or you can recommend to patients with insomnia, which uses the first line recommended treatment for insomnia, which is CBT for insomnia. So that's a self-help guide. If you're interested in finding out more about sleep medicine, we at Oxford offer a master's degree in sleep medicine. We also offer it as a postgraduate diploma, and they can be done as CPD modules. And we've got modules that cover the physiological basis of sleep, looking at the neuroanatomy, etc., and looking at sleep medicine introduction, circadian rhythms, and sleep disorders in that area, insomnia, sleep-disordered breathing, sleep-related movement disorders, hypersomnias and parasomnias, and sleep in specialist populations and in society. It's a fantastic course, and I'm very, very happy to talk more about it with people should they wish. But just to say thank you very much indeed for being here, and it's been a real pleasure to talk to you.
Hi everyone, hope you can see me okay and see the presentation. Just a huge thank you to all of our external speakers today from me personally, and also to Dr. Gavriloff. Covered a lot of information very easily, very easy to understand, and it's a very good introduction, even though we had a very short time frame to deal with. I'm Caitlin Irwin. I'm going to be kicking us off with focusing on sleep issues in adults in a community setting, so more of a general practice setting. The hashtag there is Medics.Sleep if you want to get active on Twitter and Instagram, and also on the Slack, and we'll answer any questions you have there. So I'm going to be covering really three main areas. What is sleep, insomnia, and finally sleep hygiene, and beginning to talk through how to take a sleep history, which will be followed then by Dr. Badia, who's going to show you how to take this information and use it in practice. So if you want to join in with the live polls, that would be great. I want to get some interaction. So we'll post a QR code on the Slack if you're on there currently, or if you want to go onto slido.com and use the event code 78784. And I'll have the code up in the corner whenever those polls will be going live. So this has already been quite well covered by Dr. Gavriloff, so I'm not going to spend too much time on it. But in the red there, you can see the rapid eye movement sleep, and stages 3, 4, which are the slow wave non-rapid eye movement sleep. And you can see that, although we previously talked about it, that you cycle between these as the night goes on, with a little bit of wakening in between. And just to highlight that if you're very tired or very sleep deprived, that you will drop from awake to slow wave sleep very, very quickly. So if you're woken during that time, you might feel very groggy or confused. We also sort of spoke about the circadian rhythm, which is our body clock, what we tend to go through in about 24 hours. And this is aided by the secretion of melatonin. So that's inhibited by light coming into the eyes and stimulated whenever darkness sets in. So it takes about an hour and a half for the melatonin to begin to be released, and then you feel a bit tired, a bit groggy. And this is what helps tell you you're sleepy, it's time for bed. So what is insomnia? Well, the picture on the left here, you probably won't be able to read the writing underneath it, but this is Hypnos. He's the ancient Greek god of sleep, and his Roman counterpart was Somnus. So the astute of you will know that kind of sounds like hypnotics, the drugs that we use to help with sleeping, and insomnia. And that is true. The Latin insomnus means sleepless, which pretty much sums up what insomnia is. So it's a difficulty getting to sleep, or a difficulty staying asleep, early awakening, or non-restorative sleep. And like Dr. Gavriloff pointed out, it could be a mixture of all 4 of these. This is despite adequate time and opportunity to sleep. So this is what would sort of begin to highlight to you what the difference between insomnia and short sleepers. Short sleepers tend to may have difficulty getting to sleep or staying to sleep. They feel very tired, and that isn't because of adequate time. They may find difficulties getting to sleep because they have inadequate time, so they're working quite a lot. Maybe they have a couple of jobs on the go, or they have family commitments like young children, so they're not getting that opportunity to sleep. And this results in an impaired daytime functioning. So they're struggling throughout the day. So this is happening on 3 or more days during the week for over 3 months. So it tends to occur for quite a long period of time. So who does it affect? That's what we mean by epidemiology. It is fairly common. It affects 1 in 3 adults within their lifetime, and this increases as we age. So 1 in 2 of over 65s would probably meet this criteria at some point. Typically affects females more than males. And so if you want to jump across to the Slido with the code 78784 and think about what the causes of insomnia or even short sleeping might be. And we can have a look at what you're thinking from there. So I'll hop across to the Slido and we can look. Too much coffee, obesity, stress, temperature, noise. They're all really, really good answers. Stress seems to be quite a common one, possibly from personal experience. Coming up to exams, you know, you're very stressed, you stay up late. Light exposure from phone, yeah, that's good. So that's the blue light that we spoke about earlier. Blue light is going to impact melatonin secretion. So I'll hop across back to the slides. So some of these you've rightly suggested that they are correct, and I find it easier myself to break them up into 3 sort of main categories. So more lifestyle, jet lag, shift work, stress, young children. And Mitchell, one of our junior doctors, might shed a little more light on shift work. Psychological, so things like depression, anxiety, grief reactions, mania, addiction can also impact on sleep, which unfortunately is a cycle, because a low amount of sleep is also going to negatively impact on mood, possibly worsening depression, anxiety, grief, and things like that, and it becomes a cycle. And lastly, physical. So medications, things like steroids. So any of you in practice or any of you who have siblings or yourselves have had asthma, if you've had a period of exacerbations, your asthma's gotten worse, you may have been given some oral steroids, something like prednisolone, and you'll find that parents will often comment to you that the kids are bouncing off the wall after they've had them and they've gotten a bit better. It tends to make them a lot more energetic. In addition to this, medications like SSRIs, so selective serotonin reuptake inhibitors, that are used for depression, anxiety, something like fluoxetine or citalopram, unfortunately can also have a negative effect on sleep. Things like pain, which highlighting the importance of good pain management. Itching, which is something Sarah will talk about later in her sleep and dermatology part of the webinar. Tinnitus, so a high-pitched ringing or buzzing in the ear. Sweats, you find that some quite common in menopausal women. And that might be a contributing factor to why they want hormone replacement therapies. They come to you, say they feel awful, they can't sleep, they're throwing the blankets on and off, it's impacting them, it's impacting their partner. Also nocturia, which means getting up in the night to go urinate or to pee. When you think of this, you think of an older gentleman, prostate gets enlarged, they need to go to the toilet more frequently throughout the night, and that can severely impact sleep. And lastly, sleep apnea, which Vinay will cover in his talk later on today. This will highlight in the consultation portion that is very important to ask in most consultations, no matter what the patient is coming in with, that you ask about their sleep. Because if they're coming in with something like Crohn's or ulcerative colitis, which is a bowel disorder, inflammatory bowel disease, their sleep may be very negatively impacted because they're getting up so often during the night. So again, over on the Slido, we've all probably pulled an all-nighter, and from personal experience, I feel horrendous. So what happens to you when you've had too little sleep? And try to think about that, and also think back to Dr. Gavrilov's slides. He also highlighted some of the issues of this is what sleep is good for. So if you think if this is what sleep does, what happens if you have too little sleep, and how might that impact it? So let's activate the poll. So what happens if we have too little sleep? Poor mood, yeah, that's one of the big factors, is too little sleep can actually precipitate a mental health crisis or contribute to things like depressive episodes or suicidal ideation. Agitation, yeah. Reduced cognitive function, and that ties very well into brain fog. Poor concentration, which if you have pulled an all-nighter to study, is a really negative impact, because you get to your exam and you think, oh no, what did I learn? Yeah, palpitations, irritable. Okay, so let's see what we've got on the slide here. So what happens if we have too little sleep? And most of them have been covered. Tired, irritable, brain fog, so the poor concentration, lower libido. If you pulled an all-nighter, you're probably going to be hungrier. I tend to find that, and it's usually not for foods that are typically labeled as healthier for you. So this is because it lowers leptin levels and increases ghrelin levels, and that's what makes you feel hungrier. Dangerous driving, it's estimated that about 10% of road traffic accidents are a result of tiredness. Over a long term, obesity, and you can see how that might tie into the hunger. Heart disease, also hypertension, which I'll cover a little later. Diabetes mellitus, which you could tie into the obesity, but also specifically with type 1, and with type 2, you can get a poorer sugar control. And also it has been identified in a couple of studies that it may increase risk of cancer, colorectal cancer and prostate cancer, because it decreases the, and this might be slightly over the head of the aspiring medical students, but any questions, ask on the Slack. Because it decreases the natural T killer cells, which goes in and clears out any cells that have mutated. So sleep disorders are very common and very debilitating. If anyone has known anyone with insomnia or another sleep disorder, you can see that it is very, very debilitating and it impacts all aspects of life. So how do we begin to manage it? So we would advise sleep hygiene, which I'll cover a little later on, and relaxation techniques can be quite helpful. You want to try and identify the cause, and we spoke a little bit about that earlier, but we'll also talk about that in the next couple slides as well. And sort of first line, you'll want to be offering cognitive behavioral therapy for insomnia, so the CBTI. And Dr. Gavriloff highlighted that there is a quite useful book that you can recommend or even read yourselves. So sleep hygiene, there's quite a few parts of it. And the easiest way I find to remember it is by the word sleep itself. So S, schedule. You want to find what works for the person. So figuring out when they want to get up or when they need to be up by. So say that's 7 for work. They want to work back about 8 hours. And it will take a little bit of time to figure out how many hours they personally need. Like Dr. Gavriloff said, it's not a one size fits all. So some people may need 7 hours sleep. I personally need 9. And that's what helps you feel most yourself, most productive, most human. So count back those hours, trial it and see what works for them. Limit stimulants or alcohol. So stimulants, we're talking about things like caffeine, and you'll want to avoid taking that quite a few hours before bed, because the half-life or how long caffeine lasts before it's metabolized is quite a long period of time. So generally would recommend that people stop around sort of 3 or 4 p.m. at the latest. Also things like nicotine. So if someone's a smoker, you'll be wanting, obviously wanting them to try and cut down or stop completely. But in terms of sleep specifically, trying to reduce that around bedtime. Alcohol is quite a tricky one to talk to people about, just because people may drink because it helps them initially fall asleep. It helps them to feel relaxed and sleepy, but it will disturb the quality of the sleep. And that is something that you will have to talk to them about and help to talk to them about why that might be. E for exercise in the daytime. That's good. You get outside, get some blue light, make you feel a bit more awake, and help maintain that circadian or body clock rhythm. Exercising in the late at night or just before bed would not be recommended, just because it is going to increase your adrenaline levels. You're going to feel a lot more hyped, a lot more awake, and that's not something you want to be doing before bed, because you'll struggle to drift off. Eliminate a hostile sleep environment. So someone posted on the Slido that light from phones is going to impact sleep. So that is true. So you want to avoid blue lights before bed, like an hour and a half before bed. So whether that be a blue light blocker, which most phones have nowadays, or even probably better to keep your phone out of the bedroom if possible, and finding something that you can do to relax, like reading or yoga or meditating or something like that that you find relaxing. Again, low noise and low light. So that might involve putting in earplugs if you live in a noisy area. You just need to watch that they don't. Push earwax deeper into the ear canal and compact it, because it can impact their hearing over time. And low light, so it might involve an eye mask or investing in some darker curtains, keeping the room a cool temperature, so that might involve closing the curtains during the day so that the room doesn't get quite warm during the night. And finally, P for psychotherapy. So that's the CBTI that we previously mentioned. So in terms of if non-pharmacological management doesn't work, you would consider prescribing a very short-term course of hypnotics, so Z drugs like zolpidem or sulbaclone. And that's something you can look at in the BNF on Google, and they'll highlight the dosages and things like that. In terms of offering the Z drugs, they're not first line because of the risk of tolerance and dependency, and also that although it will help restore your body clock and help you get into a rhythm of forming a schedule, it isn't as restorative because it's not mimicking psychological or physiological sleep. So we spoke about the sleep hygiene. Now we'll cover a relaxation technique that you can do with people. So we'll go through a few cycles of this, but just to introduce it. So you would say to them, if they're lying down, arms by their side, try and relax. Think about where they're holding tension. This is commonly in the jaw, in their back. Try and relax that. If they're sitting like we're doing now, place your hands on your thighs or on the desk, somewhere steady, somewhere stable. Think about the connection with either your thighs or your table. Place your feet firmly on the ground and breathe into your belly, so you're pushing your diaphragm down, trying to get nice and relaxed. And if you're struggling to breathe into your belly, that's okay. A lot of people find it difficult to do the first few times. You can place your hand on your belly if you find that easier and feel it rise and fall. So you could do this. You recommend that you would do it for 3 to 5 minutes, or as long as it takes for them to feel relaxed. So we're going to do this for 4 seconds. It's very easy to teach. That's why we have the square. 4 sides, 4 seconds each. So we're going to breathe in for 4. And hold that for 4. And breathe out for 4. And hold that for 4. Now, some people might find that difficult if they have breathing issues or things like that. Tell them not to get disheartened. It happens. Tell them to find a period of time that works for them. It may be a little shorter, but this is just because it's the easiest way to teach it with the square. It's easy to remember. And again, focusing on where you have stress and releasing this, and breathe into your belly for 4. And hold that for 4. And breathe out for 4. And hold for 4. Okay, so now you're starting to get the hang of it, and the more you practice it, the easier it becomes, and the more comfortable you get with it, the easier it's going to be to teach this. So one final time, and I'm going to do it along with you, so I'm not going to speak so I can get the most out of it. Some people might find it easier to close their eyes, and if they're doing this in bed, that might even help them drift off to sleep. They're feeling tired, they're feeling relaxed, they've got their eyes closed. So follow along. And hold. And out. And hold. Okay, so we jump across to the Slido now. Hopefully everyone's feeling relaxed, feeling a little more at ease. So if you want to jump across to the Slido and get prepared, we'll be asking some questions there. So someone comes in and you're asked or tasked with taking a history. They've come in about their sleep specifically. So you want to get what their baseline is. So what is their current sleeping pattern? So that will involve when is their bedtime. So they might say they go to bed around midnight, and we'll have a little vignette or a case after this to highlight some of the issues. How long does it take them to fall asleep initially? So that might indicate to you how tired they are. So if they go to bed and they fall asleep straight away, it means they're probably a little sleep deprived. Or if they lie there for a long time, you're going to want to know why is that. They have thoughts racing, they have issues with anxiety or something like that. Do they waken during the night? So when are they wakening? How many times are they wakening? And for how long? Because as it was pointed out earlier, we may waken for a very short period of time during the night, and we tend not to remember it. But if they're awake for a very long period of time, that sort of indicates that there may be an issue there. You also want to know why they're waking up during the night. So it might be if they have young children who are having nightmares or want some company. Is it because they need the toilet? Why is that? And is this the same pattern on weekends as it is on weekdays? And also, what is their pre-sleep routine? So what do they do to get ready for bed, or what do they do before bed? So that will involve things that we previously spoke about. So what is their sleep environment like? Is it cold in the room? Is it noisy? What's the light like? Are they using any screens? Do they have any filters on those? Do they take any medications that we spoke about previously? What are their feelings about going to sleep? Do they have a lot of anxiety around bedtime? Do they smoke? Do they drink? Caffeine? Do they eat any dark chocolate before bed or have any coffee late at night? When do they exercise? And so on and so forth. And a lot of this is going to be you following cues as well. So you're picking up on what they say, and you'll probably do this in everyday conversations. So just trust your instincts, follow your gut, follow the cues that they're putting down. And it will probably take a little bit of practice to remember all of the questions, and also just to get comfortable with your style of talking to a patient or to someone. So practice it with your friends or your family. Don't get too disheartened. That's what practice is for. It happens to everyone. And they will be very understanding if you forget and come back to another question later on as you've remembered it. What happens during their sleep? So that kind of ties in with waking up. But also you want to sort of try to start to rule things out. So then I'll talk later about apnea. But do they notice that they're waking up a lot? Does their partner complain that they snore very loudly or gasp for breath? Do they have any abnormal movements? Are they talking in their sleep? Are they grinding their teeth? Do they have any issues with sleep paralysis, which Rita will cover after this? Any issues with hallucinations or sleepwalking or nightmares or night terrors? Tends to be more of an issue in children and adolescents, so Rita will be covering that as well. And finally, what impact is this having on their life day to day? So are they taking naps? Are they do they have a lot of daytime sleepiness? So you could use a a questionnaire, sort of like Epworth sleep scale, and that can help sort of quantify how tired they are during the day. Is it impacting their work? Is it impacting their social life? Because if someone's very irritable, very tired, they may not want to go out as frequently, or they may be having issues on their relationship. And how is it impacting their mood? Because it was highlighted earlier that on the Slido that it can precipitate mental health crises, but also can just generally make people feel a bit low in their mood. And the last thing here, it's not actually on the slide, but when was their last good sleep? So when did they last wake up and they felt that was a great sleep? I feel very rested. I feel great. I feel very productive. So ask them, why was it good? When was it good? And what changed? And that can kind of, part of that will highlight to you maybe possibly what the cause of this is, but it's also quite a good motivator, because it can be very, very difficult, because it takes a lot of self-motivation to change their sleep, because it's a routine and habits are very hard to break. And they'll need something to hold on to and look forward to whenever they hit hurdles along the way. So onto the vignette. So if you hop across the Slido, the code is 78784, and try and highlight some of the issues that this person is having. And if you use the sleep on the side there, that can help jog your memory a little bit on what might not be the best thing to be doing around bedtime. So we have a 54-year-old male. He presents with sleep issues. He goes to bed at 2 a.m. and he drifts off easily. He wakes at 5 a.m. for work. This has been his routine for the past few months. He is extremely tired, and this is negatively impacting his work and his relationship. He naps for 2 hours after work. When he wakes, he goes to the gym at 8 p.m. He has dinner with 2 glasses of wine before watching TV in bed. He is a smoker and has his final cigarette just before bed. He and his partner have not noticed any issues during his sleep. So I'll hop across the Slido here and have a think of any issues that there might be with his sleep. So what are the important parts of his history? So think again, how many hours of sleep he's getting, what his schedule. It's great wine. Yeah, so alcohol before bed, not recommended, especially if he's drinking 2 glasses a night every night. So you want to sort of quantify how many he's having. Smoking, so the stimulant again, the nicotine. Naps, especially late on in the day. Fine earlier in the day, it may just push sleeping back a little, but napping after work can severely impact when you're going to bed. Exercising just before bed. So what we're seeing here is basically, this is everything not to do when you want to go to sleep. So we'll hop across. You guys have pointed out the majority of this. So highlighted in red, his schedule is very late and he wakes up very early, so very small amount of sleep. The napping at night, exercising very late, the alcohol, the TV, so that's the blue light, smoking. So what we've covered, or what I've covered, is sleep is part of the natural body clock. It's essential to good health. Insomnia is fairly common, affecting about 1 in 3. And always advise sleep hygiene first in combination with cognitive behavioral therapy for insomnia. So now I'm going to pass it across to Dr. Badia, and he's going to show you how to use all of this in practice. If you have any questions, ask them on the Slack and we'll answer them for you there, or save them for the Q&A later on today. And if you have any questions in the future, message us on any of our social medias, and I've provided my email there as well. Thank you very much, everyone, and I hope you have a great rest of your day.
Hello, thank you, Caitlin. That was a fantastic talk, and thank you, Dimitri, also for another brilliant talk. You've given us a great head start, so I'm really looking forward to the next part, which is titled The Sleep Consultation. This comes in 3 parts. The first part is where I'm just going to chat and check in with you to bring out our best so we're ready for our sleep consultation. Next, we're going to be joined by a Wonder Woman called Mo, who is a member of the public who has very kindly offered to have a live sleep consultation with me. And then I'm hoping that we can then have a little bit of time to hear about some of your feedback, your thoughts, your ideas, questions and suggestions. So I might call Caitlin's help in just to talk about some of the elements on Snapchat that may have come in. So what I'm going to do is go to screen share first of all, and hopefully be able to share my screen. Let me do that. And go to the title slide. Let me do that. Here we go. So firstly, hello, welcome. So I already said we're going to be talking about sleep, the sleep consultation, and building on the groundwork that you've already seen so far. And I'm so pleased that Medics.Sleep is here and doing this, because we've all learned that our future does depend on our dreams, and this is your dreams as well as those you can support, those you care for. My name is Dr. Bhatia. If you want to get in touch with me, just contact me via Really Wellbeing, and if you want permissions about the slides, just get in touch with me via that. So I'm hoping by the end of our chat that we will all sleep better, and it's rather a bold ambition, but I'm up for that. And we're just going to touch base briefly on who, asking, are you a doctor or a student doctor who asks about sleep? Then what types of sleep consultation you might encounter, and you may already have family members who have asked you about sleep, or maybe even thought about your own sleep. So thinking about that, thinking about why and how you can make every contact count, but focusing mostly on the how. And I'm going to share a consultation model that I've developed that I now teach to GPs and student doctors, as well as the general public, about communicating effectively, because we all know that information alone doesn't change behavior. It's how we share and embody that information that makes the difference. Before giving you a chance to have a try, you're going to encounter some new skills, so you're going to get used to this circle, which we might meet. And I'm also going to just give you 4 key questions that you might ask, which are: what's going well, what's not so good, what could you improve, and when? And we'll put them into practice, hopefully, so you can see it too. And once again, I'll have some pauses just for any thoughts and feedback about what might work for you or questions you might have. So the key message I'd like you to take home from this, and for any consultation, is that no act of kindness is wasted, and that's especially to yourself. And so very bravely, I'm going to ask myself, am I ready? I'm going to be kind to myself and harness the power of Julie Andrews from The Sound of Music, which is a great resource if you want to sleep well. Virtually every aspect that she does with those children will help you sleep better. And I'm just going to realize we've been sitting in this webinar for over an hour, and so our bodies are slightly tired. We haven't had that much sunlight, so I'm just going to ask you, just like with Caitlin, if you could pause and breathe with me, and just take a deep breath in and stretch your arms, and then breathe out. So you're now ready to consult. And I do that before each of my consultations as a reset and to tune myself in so I'm ready for the next step. And if you've got some water or a pen and paper along the way, that would be great too, because you might want to draw something. So I'm going to begin with a question. Can you remember a conversation or a consultation that helped you bring out your best? So here I've set out 2 scenarios. So one is you might have been paused like one of these characters in a waiting room, about to meet someone, perhaps a clinician, or maybe just spoke to a friend who listened and empowered you and got the best out of you. Now, we know sleep is really important and under prioritized. 2/3 of our planet potentially are short sleeping, according to WHO. So I'm wondering if you could empower someone, potentially by helping them sleep well, would you? Well, you being here suggests that you would. And so I would suggest that you are a doctor who asks about sleep, that you would empower someone if you could. even if it wasn't easy, expected, expedient, so not particularly fast, or appreciated at the time. Now, many of you are going to be student doctors, and that's you too. I trust you, you're almost a doctor, and you make a difference already. You are already talking to family members, to members of the public, or patients you might call them, and your contact makes a difference. We know it only takes 30 seconds of contact for someone's trajectory in life to change. However, you might not see it at the time. And you have that longer bit of time to talk with patients. So potentially you could ask them about their lifestyle, ask them about their sleep, and just realize that no act of kindness is wasted. And that's why I talk to student doctors, and you can see the picture of someone on the team I've just been giving a 6-week course to all about sleep at Bristol. And myself, realizing that sleep matters, I've set up Really Wellbeing, where I train GPs and also student doctors, and also have free wellbeing sessions for members of the public who get in touch. And I know that actually improving their sleep improves my sleep. So it's an act of kindness for myself. So we're going to go on to what is a sleep consultation. Well, it can present in many ways. In my work as a general practitioner, some people just come up to me straight and say, you know, it's my sleep, doctor. I'm exhausted, or I'm struggling to stay asleep, or I'm struggling to get to sleep, or I wake up and I'm just not right. But then again, it's also present in other aspects. We've already learned from Dimitri that it's present in all aspects of life on this planet, and also in all aspects of health. So when your mood is impaired, also that impacts potentially from your sleep, as well as someone could present with issues to do with their heart, stroke, cancers, accidents, immunity, fertility issues. So virtually every consultation could be a sleep consultation. And that's why NICE, the GMC, the NHS Forward Plan, and also something called Making Every Contact Count have recognised that sleep counts, and just asking, how's your sleep, really makes a difference. And Caitlin beautifully described the aspects of the sleep history and various questionnaires that can help you assess someone's sleep. My challenge then is, how can you consult knowing you've got those skills? We already know it's common, we already know it's important, and I'll just say in the UK it costs billions, potentially just in terms of presenteeism and underperformance, let alone the health implications. And that's the equivalent of like the education budget for this country. It's pretty big, and it's a neglected superpower. So if you harness it, people will recover better. So why don't we ask about sleep? Well, there are many reasons. For some, it feels too personal. For doctors who are already busy, or students who are already trying to consult in other things, it might seem too tricky. They might feel like either them or the person they talk to won't have enough time, but we already know 30 seconds count. There's also the feeling that talking won't help, and the person you're talking with may be just too tired because they're short sleeping to respond. So my job is to make it easy for you, and this is how I've set it out. So each of you are going to have your own ways of communicating, and I'm just offering you this as a way of navigating it. And it comes in this simple acronym, which is called ICARE. And I stands for inspect, C stands for connect, A stands for activate, R stands for respond, and E stands for enjoy. And here's this member of the public, they're coming along, they're connecting with me, we're going to get activated, so we're going to get in the best state, we're going to respond the best we can to the situation we find ourselves in, and then we're going to end joyously, hopefully with a sense of empowerment. And the sorts of questions I'm asking myself as we go along are, am I ready at the inspect phase? And that we've done already. Are we a team? Are we connected? Are we ready? Are we activated in our best state for action? And then what are we going to do? How are we going to respond, and when? So without further ado, I'm just going to talk to you a bit about what it means. So someone comes along who's short sleeping, or perhaps not even aware they're short sleeping or struggling with insomnia, and then they connect. And then rather than hedging in this trajectory of further problems, we have this opportunity to flow around and have a smile at the end of the day. And that change of direction can happen in two ways. So someone could bounce off me. I could come in and just tell them what I reckon you should be doing is, but we know that doesn't work. And it's also painful. It sets up a conflict, bounce situation. What I'm hoping is we can actually empower with that sense of flow around that cycle. So someone comes out the other side empowered and brings out the best in me too. And that's where that inspect, connect, activate, respond, and empower comes in. I won't go into too much detail, but I've put the slides there so you can just see them. But basically, the inspect phase shows that you matter. Your physical health strongly influences health practices. Also, your mindset, your sense of seeing someone's beauty and potential makes a massive difference. So the phrase I use is it may take two to tango, but it only takes one to ask. And from Dame Carol Black's talk, she frequently says, sorry, I won't go into that in a moment, but says that we need to model the behaviour that we want to see. People do what we do, not what we say. So we need to embody it too. And there's lots of evidence that our state of well-being has a massive impact. The connect part is about joining as a team and connecting not only with someone's presenting complaint, but their life situation, their mindset, their emotions, their body, their life situation. And in the process, you establish rapport and trust, which then makes them receptive to change. And if in doubt, I say flash. So first listen, affirm and summarize humbly, acknowledging there may be hidden agendas. Before we activate, like this hooker, this team, they set themselves up to be in the ready state for action. And there are many tools you can use to do it. And you may have encountered some already. And I'm just going to put a few on the next page. And they are behavioural tools like the oars or the down cat about developing desire, ability, reasons and need, commitment, action and taking steps of motivational interviewing, or very elegantly, the tiny steps fog model about how behaviour is a function of motivation, ability and prompt coinciding at the same space. And I'm not expecting you to have these skills yet. They're things you develop with time, but I'm just putting them there so they're reference so you can come across them in the future. And Caitlin beautifully described how you can respond. So what can you do to help someone sleep better? And her sleep model is brilliant. I just happen to have come up with my own because I know that great sleepers set kind reminders. If there's no when to when they're going to do their things, it's not going to happen. And so I work out when in the day it's the ideal time for them to do it. And then they decide, do I want to do it and how they can. And if you want to download my guide to sleeping well, just go onto reallywellbeing.com and there's a free guide on the homepage. And I go through this strategy called Sleepers with most people I meet. And it's got all those things that Dimitri and Caitlin were mentioning in the past. And my aim is to empower and enjoy the process. So I want to help them help themselves so that they can come out empowered and stronger. And I want us both to be empowered and to enjoy the process too. And I try and engage with an element of rehearsal, adaptation, building their confidence and their community, because we know community and someone's environmental situation impact on their performance too. And so we're going to try it now with the help of Mo, and I'm going to ask 4 questions. I'm going to ask her, what's the best thing for you about your sleep? So rather than starting with a problem, I'm starting off with what's going well, so that she then connects in with what her motivation would be. I'm also going to ask her, what's the challenge? Whether it's an issue to do with quantity, quality, periodicity, perception, or maybe all 4. Then I'm going to ask them, how could it be improved? Engaging and asking her to be empowered and finding the easiest thing she could do. And we know from Fogg's behavioural model that the tiniest behavioural change knock on domino style onto the rest of someone's habit changes, and they will naturally move on to the next bigger challenge. And then very specifically when. And then once again, I'm going to ask, just touch base with Caitlin now before we go on. Caitlin, have there been any questions, observations or suggestions so far?
So far, everyone seems to be loving it, fairly happy, no questions just yet.
Great, stunned into silence. Well, if they come, that would be great. But I've just got one question for anyone else who would like to as they go along. What question would you ask to open your sleep consultation? So I've got a set of openers by the end. So I'll open the floor to what openers would you do? And I don't know what I'm going to say when we meet Mo, but here we go. I'm going to log out of this and we're going to meet Mo, if I can. Ooh, let's escape here and come out of screen sharing. And I'm hopefully going to come to just Mo and I. So Mo, nice to meet you. Nice to meet you. Thank you for showing up. How are you doing?
Really good today. Really good.
Brilliant. Well, may I connect with you and ask if you could connect with the team that's here? Could you tell us just a little bit about yourself?
I'm 64. I'm still on a journey of trying to change how I think and do things, but with great success over the last 18 months or so. I've got 3 grown-up children, 4 grandchildren, and I'm very much in their lives. I work as a medical secretary. I'm generally a happy person, but can go downhill when there's lots of stuff coming at me, stress-wise. But life is good at the minute, even though there are very big challenges at the moment.
Thank you for sharing so openly. So I heard that you said you're generally a happy person and that life is pretty good. You've been through some big changes.
Huge.
And you've also boldly shown up to a talk all about sleep. So I'm hearing that sleep is important to you too. Is that right? Just by you being here?
Sleep actually is important because I would say, and it really doesn't have a lot to do with COVID, because of the challenges that I've got with family, my father, and my sleep has gone down to maximum of 5 hours, which is not great. And it's kind of like I need to get that better so that I can get up on a morning ready to greet it and go, right, okay, let's get on with it. Let's see what we have in front of us today and deal with it.
Well, that sounds great. I mean, so what I heard was that you're facing some challenges being the matriarch of a family and caring for an elderly relative.
Very much so.
Really challenged, and that you're potentially sleeping shorter than you'd ideally like to.
Very much so.
So I'm wondering if together we could work as a team to bring out the best in your sleep. And I'm cheekily wondering if what we explore will help me sleep better too.
Gosh, I hope so. It's my aim that both of us end up with something.
So most people start with the problem. So I'm going to do something slightly unusual because I want to actually switch on the parts of your body and brain that are activated and ready. So I could ask you, what's the best thing for you about sleeping well? So when you sleep well, what is the best thing?
I wake up and I'm probably going to do it and I have a good stretch and I get out of bed, open the curtains, and I look at the world and go, yes. And it's a stretch and, oh, that was really nice. I like that feeling.
So you like that feeling. So
I really like that feeling. Yeah.
It's a strong desire and it's embodied desire. Your body's feeling it, not just your mind when we talk about it. That's good. So we've got things going now.
Yeah.
Can I ask the challenging question then? So what are your challenges to sleeping well? What's your challenge?
The way my home life is, husband sits in that room where the TV is. I end up going upstairs watching the TV because we're not watching the same thing because he's catching up on football. Not interested. And then I go upstairs and then things start to go through my mind. Will I get a phone call from Dad tonight? Will I not get a phone call from Dad? I think it's probably switching off. Switching off. Yeah.
And thank you. So you've mentioned quite a few elements there. So if I can share what I've heard, you mentioned switching off and that wind down process before getting to bed. So sometimes it's hard to fall asleep at the start.
Yeah.
And then sometimes you're waking up in the night, sort of running through thoughts that haven't quite been processed.
Yes. Yeah.
And that because you and your partner are slightly desynchronized in your sleep schedule, you're not getting that comforting oxytocin release that we know as a tribe we've evolved to learn to do. Yeah. So would it be useful to look at ways that might help you switch off and wind down before bed?
I think that probably is the crucial bit for me because I don't wind down at all at the moment.
Yeah, and
Yeah.
sometimes just taking one small thing can make a big difference. And what I might suggest we do is we could look at the physiology, some of the emotions as well, and some of the factors. So I'm going to be cheeky now. You're going to teach all of us already. So if there was one thing that worked well in the past for you, that you think, you know, that was a day I wound down really well, what would that be?
That would be when the TV was not in the bedroom and going to bed was going to bed, not going up to finish my day before I go to bed. Does that make sense?
That makes sense. And what you've described really eloquently is the difference between the changes in society in the last 50 years, since TVs have migrated into our bedrooms and we've got screens, is that we get artificial light that then stops us from releasing the sleep start hormone called melatonin. And so as a result, our starting gun for sleep doesn't start until much later. So it delays our sleep trigger by about an hour and a half. So I'm wondering if we could potentially reduce your exposure to artificial light before bed. It might help you get into that sleepy zone. Could that be possible?
It is possible if I unplug the telly.
If you unplug the telly?
If I unplug the telly and go bye to the telly.
And that way the bedroom becomes like a sanctuary, and then the bed becomes solely a shrine for sleep and snuggles.
Yeah.
Now the thing is, behavior change, we can have great motivation now while we're talking in a sleep consultation.
Yes.
But it might be different after a long day and your old habits are in place. So I'm wondering, what would make it so easy that even on the toughest day, you wouldn't watch TV in your bedroom?
If I walked 5 steps across to the bedroom that doesn't have a telly in it at all already.
Okay.
Believe it or not, here it is that simple. 5 steps across, there is a room without a telly in, which is where my daughter comes to visit because she hates tellies in the bedroom.
Yeah. So there's lots of things. So one is you could go into a different bedroom.
Yes.
But it's setting up a new sanctuary, which may be challenging.
Yeah, that will be challenging.
Beautifully mentioned is make it slightly harder to plug in the telly by actually unplugging it.
Yeah.
Now I'm getting a sense that removing the TV from the bedroom may be a step too far.
Yes, it will be. And unplugging it wouldn't create my husband problem because it's attached to this, that, and the other. But I wouldn't be able to replug it because I don't understand how he's sorted all this system out. So I could quite happily unplug it. That wouldn't be a problem. And when he comes up to bed, because I've got a sleep timer on the TV, which I put on for an hour before I go to sleep, so that there is noise and the TV's on whilst I'm trying to go to sleep.
Yeah. So I've already heard you've got a sleep timer and you use a timer. The challenge is if the TV's plugged in or easy to plug in, you're more likely to do it because it's easy.
Yeah, I am. But because it's complicated, once I've pulled it out.
So you pulled it out, and I wonder if we could make it even more a kind of a chosen thing rather than a habit thing. Is it possible to put a little sticker on the plug of the TV? Maybe with a couple of words that says, my sleep is important, or sleep well, yay in the morning, which is what you tell me. You wake up with a yay in the morning.
Yes. Yeah.
And so it's a choice and it's an active choice, and you've just got a little word from your good self, your best self, before you plug it in. How would that be?
That would be great because I'm more a visual. If there's a sticker on something, I read it, and if there's a happy face, I react to it. So that would suit my personality. Yeah.
If you were to go up and put that sticker as you unplug the TV, when would you do it?
Probably when we finish, because I'm motivated.
Yeah. Okay.
And if I don't do it when I'm motivated, it's not going to happen. And I know that.
So on a scale of 1 to 10, I'm just going to ask you now, how important would you say a good night's sleep is for you to have a great life and that, you know,
At this moment in time, a good night's sleep is what I need physically and mentally. At
So a
this
score out of
moment
10?
in time, it really is. I've got big
Score out of 10,
challenges
how
coming up.
How
Sorry,
important out of 10 would you say?
10.
A 10, okay, so that's really important. You know,
Yeah, no,
that's
it's vital.
wow. Excellent. And then how confident are you that you're going to make that tiny little habit, that tiny little put the sticker on the TV? On the TV.
I would like to say, right, if I can get my children's behaviour chart for my grandkids stay with me, there's a beautiful smiley face on there.
Yeah.
I can pick that up and I can go up and I can put that on. The challenge is, I think maybe I need to put a new sticker on every night, go up and go, I'm going to do this tonight. So that I make it stick
I
every
wonder
night.
if as soon as we finished our conversation, you could dash upstairs and pull out the plug.
Absolutely.
And then when you do it, will you give yourself a high five from me?
Yeah.
Yeah?
Yeah. Yeah. Yeah, definitely. Definitely.
Could you practice that high five now? We're just going to rehearse it. Cracking. And that brilliant. So that was like a rehearsal. You've actually had a practice celebration.
Yes.
And just doing that is all I'm going to ask you to do. Interestingly, we know these little acts, these tiny habits, acts of kindness, make all the difference. They just knock on.
Yeah, they do. Yeah, definitely.
Great. Well, hopefully we've gone right the way round through our cycle. And I'm going to ask you now, how empowered do you feel? Do you feel like it would be an okay time to...
All I'm going to do is my Julie Andrews.
Okay. Yes,
yeah, because I'm motivated because I knew I needed this. Yeah. I believe some things come to you for a good reason. Yeah. I'm ready. I am ready, and I'm going to go and do that now.
Smashing. Well, it's been such a pleasure. I also feel motivated to prioritise my bedtime routine, having spoken with you, and perhaps maybe switch off my phone a little bit earlier than I would have done otherwise. So thank you for helping me too.
No, and thank you.
With that, would it be all right to draw our consultation to a close?
Absolutely. Absolutely. High five through.
Cheers. Bye for now. High five.
Bye.
Great all. So I'll say goodbye to Mo and hello to everyone here in the team. And I'm just going to go back to share screen again. So I'm just going to share here. So I'm hoping that over the course of our chat, if this will let me, you had a chance to see how I simply connected, activated, responded, and empowered both of us in the course of that conversation, while periodically just tuning in, taking a calm breath, and pausing, just to recenter. So I was in my best state, and Mo similarly pausing in the best state too. And we ask a few questions like, what was the best thing for you about sleeping well? What was your sleep challenge? And it became clear it was about quantity and quality. And we also looked at how it could improve. But I asked Mo rather than telling her what to do. And then we really focused on when we could do it, managing our motivation, our ability, and our prompt all together. And I hope you've seen that we've worked out that you've got lots of skills that you can put into practice already. And that if there was one thing I'd like you to take home from today, is that no act of kindness is wasted. Simply showing up for 30 seconds with someone you care for, including yourself, makes a massive difference. And now I'll come over to Caitlin and just ask if there were any questions or thoughts or feedback.
I think a lot of people were talking about the openers that you suggested.
Yeah, brilliant. So is it all right to share some of those openers?
Yeah, I think the most popular was probably "How are you feeling today?" is probably a good way to start it. That's what everyone was feeling.
Yeah.
We've got some other questions. So how are we doing today? Would that be better to say we or you? How can I help you? Yeah. How can I help you today was another one, or what's brought you in today?
Yeah, and those kind openers, and it's kind of opening you to connect and establish that rapport. And then once you've got that, you can be that doctor who asks about sleep, because we know it's under asked about, and yet it's more significant than many of the questions we ask in our normal histories. And just asking, and particularly asking twice, getting the normal answer like it's okay, and then asking again, yeah. And so, really, how's your sleep? Suddenly you'll find out everyone's got a sleep story.
Yeah.
So I hope that was useful, and it's been a great pleasure sharing with you.
Yeah, it's been great. Everyone feels very motivated now. Everyone's talking about it on the chat.
Well, I'll say goodbye for now. Cheers.
Thank you very much. Bye.
Bye.
Hi, everyone. So I'll just share my screen. Hi, everyone. So I'm Rita. Thank you so much to Dr. Bhatia and to Mo. That was really informative, and I'll definitely be taking some of those tips forward. Today, I'll be talking about sleep and child health. And if you're not already in the Slack channel, be sure to check it out. It's just, you can use the QR code in the top left corner. And also use our hashtag Medics.Sleep on Twitter, and make sure you tweet us, and we'll be happy to get back to you with any questions and answers and things like that. So let's get started. So today I'll be talking a little bit about me, sleep and early childhood, so for children that are between 0 and 5, middle childhood, children that are between 6 and 12, and teenagers, so between the ages of 13 and 18. So about me. So I'm from Leicester originally. I went to Judge Meadow Community College to do my normal secondary school GCSEs. And then I went to Beecham College to do my A-levels. And then straight after that, I went to University of Lincoln. I actually studied human nutrition there, so that was really interesting. And then I went into the food industry for 2 years. I'm currently in my 6th year of medical school at Plovdiv Medical University in Bulgaria. So I just wanted to let you know that the route to medicine isn't always linear. There's lots of turns that life can take, and yeah, so it's brilliant. So that's just a little picture in the bottom left corner. So if you want to head on over to Slack, I just wanted to ask, how do you feel if you've only slept for 3 hours at night? You might be feeling a little bit like this guy. Head on over and let me know what you think. So I can't function, definitely feel like that guy, definitely, me too. Just wait for a few more. Extremely tired, not myself. Everything's a struggle. I definitely know how you feel. Groggy, unmotivated, nauseous, exactly like him, me too. So most of you did say similar things like this. So moody, yawning, irritable. But one of the reasons it's so hard to know if a child is getting insufficient sleep is that drowsy children don't usually wind down. So they don't get tired or sleepy, or, you know, they wind up instead. And so they have temper tantrums and they become really overactive, and they tend to have more daytime naps. So we'll be talking about early childhood. So their normal sleep patterns in children, why they don't want to go to bed, so any resistance to going to bed, waking up during the night, and common sleep problems in early childhood. So let's discuss a couple of these. So the normal sleep patterns in early childhood, so for children under 1, infants, they sleep around 12 to 16 hours. So that's more than half of your actual day. It's crazy. Children that are aged between 1 and 2 sleep for about 11 to 14 hours, and children that sleep for 10 to 13 hours are usually aged around 3 to 5. And as Dr. Gavrilov said before, this is usually just an approximate, so not every shoe size fits. So why do children sleep so much? Well, sleep promotes growth. Sleep promotes growth. Sleep increases learning. A baby might look peaceful when they're sleeping, but their brains are busy all night long. Sleep helps to beat germs. During sleep, children and adults produce proteins known as cytokines, and these cytokines help to fight infection, illness, and stress. Not sure if you can see me. Okay, so let's continue. So taking a pediatric history. So Caitlin, she went through a lovely history for adults. So let's explore a little bit about taking a pediatric history. So first you want to identify your patient. So you want to get their name, their age, the weight of the child, the height, and then you want to talk about the chief complaint. So why do they come in today? So you want to really find out what brings them to the GP clinic, to the hospital, and you want to ask more specific questions. So do they suffer from asthma? Because this can actually lead to night coughs, and eczema, which can lead to night itching. You also want to talk about the birth history. Were there any C-sections, or was it a vaginal delivery? And were there any complications? And then you want to be talking about immunizations. So are they up to date with their vaccinations? Then you want to ask about the developmental history. So are they meeting their milestones for gross motor movement? What about their past medical history? So have they been in before? Have they suffered from anything before? And also the family history. So any birthing problems in the past and any hereditary diseases. So resistance to going to bed. Why do children not want to go to bed? Well, they might be overstimulated. They might be watching TV with their parents or playing with their siblings. They might have had too much sleep in the afternoon, so they just don't feel sleepy. They might have separation anxiety. And so in early childhood especially, children usually suffer from separation anxiety from their parents or their caregivers. And using the bedroom as punishment. So if you use the bedroom as punishment, then the child might be scared to actually go to sleep in the same room as they're being punished in. So that might be quite difficult. So managing resistance to sleep. So leaving the child to cry is one method. You can also opt for controlled crying, or you can stay with the child. So leaving the child to cry, what does this mean? So this often works. So you just leave the child to cry in a room, and after a few nights, the crying diminishes. But this method can be quite difficult for the parents and the child. Controlled crying. So you let them cry for around 2 to 10 minutes, and then after 10 minutes, you go in and check on them and see if they're okay, and then try and get them to go to bed. And then if they continue crying, you go in after 15 minutes, and then 20 minutes, and then 25. So you just keep prolonging the amount of time. And then staying with the child. Staying with the child means you stay until they fall asleep, but then you move closer and closer towards the door. So for example, you stay with them next to the bed, and then you move closer to the drawers, and then you move closer to the door, and then finally you'll be out of the room. So waking up during the night, why does this happen? So usually children want a parental presence, and so they just really want one of their parents or a caregiver to be there with them. Half of all children aged between 6 and 12 months suffer from separation anxiety. Also, difficulty settling in the evening. And in older children, this could be because of a stressful event, such as moving to a new school, or bullying, or moving home even. So head on over to Slack and let's see what we've learned so far. So from the following, how long does the average infant less than 1 year old sleep per day? Is it 0 hours, 12 to 16 hours, 4 to 8 hours, or 25 hours in a day? Oh, we've got lots of hands up for 12 to 16 hours. Yeah, so we've got quite a lot of people for 12 to 16 hours and one for 25 hours. The answer actually is 12 to 16 hours. So well done, guys. You're right. So let's move on. So some of the common sleep problems, what are these? So this includes nightmares, night terrors, cot death, sleepwalking, and sleep apnea. So firstly, let's move on to nightmares. So what are nightmares? Nightmares are bad dreams that can be recalled by the child. And it usually occurs during REM sleep, so during the deepest stage of sleep. And the child can vividly explain the details of the dream, of the nightmare. And it's caused by frightening experiences such as scary stories or TV violence. So those are just a few of the causes. So do they need professional attention? Yeah, if they become frequent enough, then it may indicate PTSD. Occasional nightmares are normal, but if they become persistent, then they might warrant expert evaluation. So how about night terrors? Night terrors are sudden awakenings with inconsolable panic and screaming. This one usually happens in the first 1 to 3 hours of sleep, and episodes can last seconds to minutes. And the most common ages that this occurs in are for those that are between 3 and 8 years old. So what's it caused by? It's caused by lack of sleep, stress, fever, and it might present as blank stares or incomplete arousal. So you try to wake them up, but they're just not waking up. They're just a bit dazed. And they may have amnesia for an episode. So that just means that they just can't remember what happened. So that's quite different from the nightmares, because in nightmares, they could really vividly explain all the details of the dream. So does this one require professional attention? Not usually. They just require simple reassurance. So sleepwalking. Sleepwalking is also known as somnambulism. So if we break that word up, somn means sleep and ambulism means to walk or movement. So this is when you walk clumsily during deep sleep and sometimes carry out activities. And it's triggered by a stressful event. And it usually occurs when there's like zombies on TV, or something scary that's happened before bed, so a scary story. And they might carry out activities like putting on their clothes for school for the next day. So what are some tips that we could include to try and prevent, to make sure that the child is as safe as possible? So we might think about making the environment safe, especially if the child is walking into something dangerous like a door frame or something like that. And also you might want to think of waking the child up just to prevent any accidents. The other thing you can do is, if it becomes frequent enough, you can take action to put in a stair gate to actually prevent the child from coming to harm's way. So cot death, or sudden infant death syndrome. So sudden infant death syndrome is also called SIDS for short, and it's sudden and unexpected death of an infant or a young child with no adequate cause. So this happens to 1 in 2,000 babies that are found unexpectedly dead in the first year of life. So the Back to Sleep campaign in 1994 was introduced to help prevent this, and it's prevented thousands of deaths. So what does this include? It includes infants to be sleeping on their back, so with their face up and not down. No smoking during pregnancy and in the same room as the infant. Avoid overheating, so you want to make the room temperature as comfortable as possible, so 16 to 20 degrees is best. And also you want to put the child into the feet to foot position. So what does this mean? So when you have a crib, you want to put their feet right to the bottom of the crib, and you want to make sure that they can't have the blanket covering their face or anything like that. So you just want to tuck the ends in under the mattress. So sleep apnea, I just wanted to mention a few important aspects of sleep apnea in children, and Vinay will delve into it a bit deeper later on. So sleep apnea, what does apnea mean? A is cessation or stopping or no, and pnea means breathing, so there's no breathing. So why does this happen? It basically occurs when the airway completely or partially collapses repeatedly throughout the night. So it blocks the upper airway, and this causes oxygen levels to drop, and this could wake you up hundreds of times. So in adults, normally it's characterized by snoring and noisy breathing. However, this is never normal in children. It might actually be characterized by hyperactivity and behavioral problems because they're getting insufficient sleep. So as we mentioned before, it might resemble aspects of ADHD. So what is ADHD? ADHD is attention deficit hyperactivity disorder. So it's one of the most common neurodevelopmental disorders of childhood, and children may have trouble paying attention, controlling impulsive behaviors, or be overly active. So as you can see from the table, ADHD and sleep apnea are super similar. So they both have difficulty paying attention. In ADHD, you're more impulsive, and in sleep apnea, you're cranky. You're both really hyperactive, and you may have some behavioral problems such as being easily distracted in ADHD, and you may have some school problems. So how do we differentiate between ADHD or if the child has a sleeping problem? Well, you'd want to do a sleep history. So a sleep history would include their past history, any current problems, any social aspects, family disorders, and you'd also include a thorough physical examination. You'd also do a polysomnogram. So poly means multiple, somn meaning sleep, and gram meaning graph. So as Dr. Gavrilov showed us before, this is basically measuring your brainwaves, your oxygen levels, your heart rate, and your breathing during sleep. So an oximetry measures the oxygen levels in the blood, and you don't often use this method unless you don't have a polysomnogram available. You can also then measure the ECG levels, do an ECG, And so this is basically an electrocardiogram, and it measures the electrical impulses of the heart to show any underlying problems. Okay, so head on over back to Slack and try and answer this question. The Back to Sleep campaign in children with SIDS includes infants to be put to sleep on their back, avoid overheating and heavy wrapping, feet to foot position of the infant, or all of the above. Let me know what you think. Okay. Oh, we've got quite a few for all of the above. And you would be right. Well done. That was really good. Brilliant job, guys. So now we're just going to move on to middle childhood, 6 to 12-year-olds. So we'll look at their normal sleeping patterns, consistent bedtime routines, and obesity. So let's have a look. So in middle childhood, children aged between 6 to 12 years old sleep for around 9 to 12 hours a day. So by this age, most children will get enough sleep in an overnight session, so they wouldn't need necessarily any naps during the day, and this allows them to then take part in after-school activities, sports clubs, and things like that. So they're getting more out of their day. So a consistent bedtime routine. Why don't children go to bed on time? Well, they might have had a busy day, and so just got too many things to do. They might be playing with their friends and might be busy with that. They might just want the freedom. So they might just say, nope, I don't want to go to sleep. And also parental inconsistency. This includes, for example, if a parent puts the child to bed at 8 o'clock at night on a Monday, and then at 9 o'clock or 10 o'clock on a Tuesday, and then 6 o'clock on a Wednesday, which is a bit extreme. And then there's no regular routine, and so it can be quite difficult. Okay. So how can we make going to sleep easier? So it requires a gradual transition. So you need to have a firm end time of your activities. So putting away any iPads, iPhones, switching the TV off by a certain time, and telling the child's friends to go home by a certain time. Also taking a bath or a shower with warm water, because this will really relax the child and put them into the mood of going to sleep and gets them ready for bed. Also bedroom transition. What we mean by this is by dimming the lights, putting away any homework, clearing any clutter, and also reading, because this is a great quiet activity and it allows the caregiver or the parent to also bond with the child. In later ages, around 12-year-olds or 10-year-olds or late stages of middle childhood, they usually can do this by themselves, so that would be encouraged. Okay, so obesity. So several authors in Australia, Japan, Canada, and the United Kingdom have reported an association between parent-reported short sleep duration and obesity. So what does that mean? So it basically means if you sleep less, you're more likely to become obese. And why is that? Well, you have decreased leptin levels. So that means you're just not full. Your satiety levels decrease, and so you become more hungry. And then also you have increased ghrelin levels, and this is the hunger hormone, and so you feel even more hungry. And you also, because you're awake for a lot longer, you have an increased appetite. And so because you're awake for longer, that's why that happens. So head on over to Slack and let's try and answer this question. So name one method to help children go to sleep easier. Loud music, baths with cold water, watching TV, or baths with warm water. Let's have a look. Okay. So we've got quite a few with baths with warm water. Great job, guys. You're doing really well with these. I hope they're not too easy, though. Yeah, you're right. Baths with warm water. So that really gets them into the mood of going to bed and helps to alleviate any stress or tension. So let's now talk about adolescents and teenagers, so age between 13 and 18. So what do their normal sleep patterns look like? And we're going to discuss two cases about Helen and Laura and what happens when they have lack of sleep. So let's have a look. So in adolescents, in teenagers, they sleep for around 8 to 10 hours. So this resembles more of the sleeping patterns of adults, which, as Dr. Gavriloff said, was around approximately 7 to 10 hours. So that is great. And now that children are getting older, their sleeping times usually get a bit later, and that's natural. And it's normal in teenagers, it's normal to have like irregular sleep patterns across the week because of school, because they're staying awake for longer and waking up earlier because of school pressures. And so many teens suffer from treatable sleep disorders such as narcolepsy, insomnia, restless leg syndrome, and these will be discussed later by Vinay. So sleep deprivation. So I just want to share this story about Helen. Helen is a 17-year-old girl, and she says that she often reaches her breaking point around 11 o'clock at night. And she collapses in tears, and for 10 minutes or so, she just sits at her desk and cries. She's overwhelmed by the unrelenting school demands, and she's desperately tired and longs for sleep, but she knows that she has to move through it. And this is because she has more assignments in physics, in maths, and in biology that await her. And so she finally crawls into bed at 12:30 a.m. And so the next morning, she wakes up around 7 o'clock in the morning, and in class, she fights to stay awake, and she just can't concentrate. She's finding it really difficult, and her mind just drifts, basically. She just needs to get through the school day, but that night she'll just have to catch up on what she missed during that first few lessons. And then the cycle repeats itself. Helen's story isn't uncommon. And the effects of the sleep routine can lead to inability to concentrate, drowsy driving incidents, anxiety and depression, and suicide attempts. So high school is a real danger spot in terms of sleep deprivation. So some of the factors that influence this include technology, socializing, and early school start times. So this can be really difficult. And Peleio says, we're not giving them a chance to dream. And that's because teenagers are often being robbed of that rich REM sleep, that rapid eye movement sleep, which is important for productivity and is one of the deepest stages of sleep. I just want to talk about Laura now. Laura is 16 and she hit her breaking point at the end of a very challenging school year. So she spent months of late nights, and she was studying and she was going to sleep around 3 in the morning. And then one evening she suffered a panic attack at home. She said, I sat in the living room in our house on the ground and I was just crying and having horrible breathing problems. Where she once had good sleeping habits, she drifted into an unhealthy pattern of going to sleep late, and she was just studying too much, and she just had too many school demands. requiring her attention. And so the experience was a bit of a wake-up call as she recognized the need to return to a more balanced and better sleep pattern. But for some teens, this toxic mix of sleep deprivation, stress, and anxiety with external pressures can tip their thinking into dire situations. So sleep is like a balm for the brain. The better you sleep, the more clearly you think, and this may enable you to seek help when a problem arises. So for more information and support, please visit samaritans.org.uk, familylives.org.uk, youngminds.org.uk, relate.org.uk, and drfrank.com. Thank you so much for tuning in today. And if you have any questions, please direct them to our Slack channel, or alternatively, you can contact me at tweetsbyreet, or that's my email address. So thank you so much, and I hope you enjoy the rest of the day. And we'll be joined by Dr. Mithil Masuria next, talking about night shifts. So thank you so much.
Hello. Hi, so my name's Dr. Mithil Masuria. I don't know if anyone else is able to reply here and let me know if they can see me on screen. Yeah, okay. So if you're all there, so I have about 15 minutes to talk about how to prepare for night shifts. So what I will do is I'll cover the aims and objectives, tell you what I'm going to talk about, try and make it as relevant to you as possible, and give you some insight into not just how to prepare for them, but why you're preparing like that. So hopefully you can take something useful away for today. And this is general stuff. It doesn't require any prerequisite knowledge as such. So it'll be a bit easier to take in compared to some of the interesting facts you've learned already. Okay, right. So going on to the aims and objectives, what I'll do is I'll put it onto this mode. Yeah, can you all see that? Hopefully you can move the cameras out the way on the side so you can get a whole view. So yeah, so the aims and objectives are to give you the truth behind night shifts, what to do, what not to do, try to give you some helpful advice. And the objectives are basically talk about some of the relevant rules and regulations, because people are often quite confused about, are you allowed to sleep on a shift or is it not allowed? To give you some ideas of my own experiences about when I've been working, and some advice on some previous issues that have happened, so that just like with everything in medicine, we can learn from reflective practice and the practice of others. Okay, so I'll start by giving you an idea of the rota, because it's important to know how shift patterns work before we go into the nitty-gritty. But essentially, before, people used to do 7 days straight of night shifts, but this was even before my time. Due to the European Working Time Directive, this isn't the case anymore. So the maximum number of night shifts you should do on a normal pattern is 4 on the weekdays. So an example is, so if you look on the first column that I've given you here, that just shows NWD means normal working day, rest day is a day off, and then it shows you the night shifts. So if you look at the first column, this is actually a weekend set of nights. So when you have a Friday night shift, you'll have the day off before sometimes, depending on how the shift has worked out. But when you go in, whenever your start time is, if it's 9:30 p.m., you'll most likely be working until 9:30 in the morning. So you'll do that, then you'll go off home, sleep, get up, get ready, come back 9:30 p.m. On Saturday night, and then you'll do the same on Sunday, and you'll finish at 9:30 in the morning on Monday morning. Okay. After that, you'll have Monday off on the second line we're looking now. You'll have Monday off to rest, and then you'll have maybe a couple of normal working days and a normal weekend. After a normal weekend, you'll have that Monday daytime sort of off to do as you please. And we'll talk about what kind of things you can do before a night shift. And then you'll have like 4 days where you'll have night shifts, and you'll finish on the Friday morning. So that's generally how the rotas work. Hopefully you can, you know, if you'd like to, you can screenshot this so you can get an idea as well if you want. Okay, so a couple of seconds and I'll move on. Right, okay, so the rules. So this is confusing for many people. It's exactly what's allowed and what's not. But there was an article in the BMJ in 2016 which stated that the National Training Survey found that 25% of junior doctors felt fatigued on a weekly basis. And this wasn't even taking into account whether it was nights or long days or normal days. What affects their tiredness was stuff such as lack of beds to rest in or lack of on-call rooms. And an on-call room, essentially, if you don't know, is a room you're given maybe if you're doing a 24-hour, well, a long 12-hour day, or maybe a 12-hour night shift. You're not always given these, and we'll talk about some of the problems regarding these, because in certain specialties, when you become a registrar, you're given one, but as a junior, you don't technically have one, and it's confusing as to whether you use the mess or a ward staff room, and there's no clear rules as to where you should go and rest. And there is a lot of hierarchy there. So it's half of it's about knowing what you're allowed to do, and the other half is getting around the cultures that have been formed in the hospital or department prior to that. One good thing that they found was nurses actually take it in turns to sleep. Obviously, there's more nurses in a hospital than doctors. So when, let's say, we're covering a ward at night, if you're a doctor covering that ward, you may be the only doctor covering that ward, and maybe 5 other wards as well. There will be a senior above you, but you're doing all the major stuff that comes through. So like the bloods, the cannulas, and those kind of things, and the stuff you're stuck with, then you refer to the registrar. So with regards to nurses, there'll be 3 of them on each of the wards. So if one wants to go for a rest, and if she wants to combine her break and take an hour long rest where she sleeps for that, she's able to do that he's able to do that because they know they've got 2 other nurses looking after the area, as well as healthcare assistants, whereas a junior doctor might not be able to do that. So the next line says doctors could arrange this based on where they work. And the reason why I say this is when you're working in an area like the emergency department, where there's a lot more doctors, or the AMU, which is the acute medical unit, any area that has more doctors, it's easier to set up structured breaks. So specific times when certain doctors will go for breaks and certain doctors will be covering the work floor. So, and in those scenarios, it might be easier to do so. There are certain jobs, such as if you're the orthopedic SHO, for example, and you're covering most orthopedic things coming in, and you're only calling the registrar to wake them in situations where you're unsure. So in those situations where you are the only person they can call, that it'll be harder to take your break, or even take an uninterrupted break where you might be able to have a small nap. Okay. Right, so taking a professional approach on this, there is a doctor called Dr. Mike Farquhar, who's a consultant pediatric sleep doctor at the Evelina Children's Hospital, and he did some. He was interested in this, and he sent some questionnaires out. So he found that 16% of the people who are pediatric trainees that he asked said that naps were supported by their hospitals. So that's a very, very small number. And 31% of them said that naps were actively discouraged, and many reported a lack of on-call rooms altogether. So this builds into the next topic of lack of sleep relating to junior doctors having to commute quite a far distance. So, in the UK, when you're working, you might have 1 year or X amount of rotations in one city, but then you might have some in a district general, which is in the same county, but that could be up to 30 to 40 miles away. And some people opt to not move there due to finances, being in a rental contract, or for family reasons, be it what it may. And one interesting case that I can bring up is there was this doctor a couple of years ago by the name of Dr. Ronak Patel. He was a 33-year-old anesthetic registrar who was doing a night shift in a hospital and had to drive 40 miles back home. He sadly collided with a lorry. He knew he was tired and he was trying to stay awake, and he was trying to do so by being on the phone to his wife. He veered into the other side where there was an oncoming lorry, and he collided with the lorry. He sustained a broken neck at the scene, and police concluded that he had fallen asleep at the wheel. So that is, the extreme cases of tiredness and fatigue can cause this, and that's risk to yourself. The other thing is risk to others. For example, if he'd hurt somebody else and maybe survived, that's a problem. Or even if doing his job he wasn't able to think properly. This may affect any of you watching this right now. So it's definitely important to focus on your sleep and your rest and your patterns to avoid such problems like this happening again. Okay, so one way in how to prepare is to definitely be clear on how many breaks you're allowed, how long they should be, to make sure you always take your breaks. Sometimes in certain centers, a culture is built up of, oh, we're really, really busy, I have no time to take a break, where, the registrar might have said that and you feel like, you have to kind of stick it out with them. So if you don't ask, you don't get, and you do have to raise these kind of things, and I'll cover how you raise them later. So do try and have a nap in your break. So for me, I used to have a 12-hour shift with 2 half-an-hour breaks that I'm allowed to take, and I usually take them not at any set time, but at times when it does become a little bit quieter. Something that I found when reading online was, they said having a coffee before you take a nap is useful, because then you feel refreshed, but don't take this coffee in the last 4 hours of your shift, because then it will affect your sleep pattern once you get back home. Do raise your concerns if you are being overworked or having to miss your break. And the person or people to report this to are your junior doctor administrators when you start working, or if you're going to be working in the UK, then it will be the guardian of safe working hours. You can go to these people if you've not got your breaks, so they can look at problems and try and sort out any issues. I have known of scenarios in which on a busy surgical night shift, there was previously only one core trainee doctor, and after they raised concerns, they introduced more doctors onto that rota, so that they would also include the FY2s, so that they would be better supported for the workload that was there, and that all doctors could get their breaks and work safer. So it does work, but if we don't raise our voices, then nothing is heard, really. So my experiences, so I have worked in the acute medical unit, working with seniors and juniors. This can become very busy because everything from A&E, which is medical as such, can come through there. You can get breaks there if you cover for each other, but it's very easy just to keep on working and, oh, new patients arrived. The nurse is saying, please do this, please do that. So you do have to sometimes take a step back, go to the office, make a plan with the registrar as to who's taking their break when and who's going to cover what. So that this is feasible, and sometimes it's good to do that at the beginning of the shift. So ward cover, this is basically when you do a night shift and you're given a bleep or now a smartphone with various jobs coming through. You get typically about 4 wards to cover. Depending on how many jobs come through, you can get time, you can make time or for a break. Some of the jobs can be non-time relevant. So some of them can be, acute chest pain, which you'd go to straight away. Some of them could be, oh, this patient is up for fluids. His fluids run out in the next couple of hours. Could you come and review and see if he or she needs some more? So you can see how you can put certain jobs for later and act on certain ones straight away, which can allow you to then have that extended break time where you could fit in a nap. On my most recent job, where I did night shifts with psychiatry, on this I was given an on-call room with a small kitchen stocked up with food and an ensuite. With a bathroom as well. So they had no problems with sleeping. They had actually given you an on-call room and a bed. And the problem is with most hospital specialties taking away the on-call rooms and people not having a place to sleep, they kind of feel like they're not allowed to sleep. But some of the seniors still do have on-call rooms and they do get spaces to sleep. The doctor's mess is a good place to try if there isn't anything else available, but always check locally. So the things that I do, I try to have a nap in the day prior to my shift. So if I'm going in on the Friday night, I'll try and spend most of Friday afternoon sleeping and wake up maybe an hour before my shift. I might even try and fit in a quick workout just to make myself fully awake before I go into my shift. I will advise taking a large bottle of water in if you can, because essentially you're sleeping throughout the day, you're working at night, so you still need to get your water in. It might be hard to find an appropriate place to get water on a busy shift. So if you've got your own bottle to hand, it always makes it easier. Sometimes if you don't have a proper on-call room, but you want to sleep, it might be uncomfortable because you might only find a sofa or something. So I've actually opted to take in a travel pillow. So I just put it in my bag, get that out, put it around my neck. So if I do want to get 20 minutes or 30 minutes of a nap, at least I get a decent quality nap. I also recommend taking an eye cover because you don't know what place you're going to get. If it's not your own on-call room, you won't be able to turn the lights off. So having that makes it easier for you to do that. Please prepare your meals if you can. Try and take healthy food in. As you know, probably would have been covered, but with lack of sleep and changing in patterns, it affects your cortisol and you're more likely to make bad food choices as well. Try to eat in the first half of the night. If you eat after the night shift, try and make your meal as light as possible. This is to ensure that you get off to sleep quite well and you have a good sort of day's sleep. Caffeine later on in the shift I mentioned. This is very important. So ensure you're okay to travel home. This is going back to the case I told you about that doctor. If you're going too far, especially in a car, and you think you're tired, maybe you shouldn't drive. Try and get an Uber. Maybe don't drive in for your night shifts if you can Uber it either way. Or the other alternative is, even if you have driven in and you're still too tired, you can seek out rooms in your hospital. So hospitals normally have accommodation. And I think at my local hospital, if you can't go home after a night shift, rooms are available, and I think they're as low as £20 a night. So it might be good just to get maybe 4 or 5 hours of sleep with the curtains shut, and then when you feel fresh again, then maybe go home then. So it's something to think about. There is an option there. So in my hospital, one further thing is that you'll have a phone where all the jobs come through. The coordinators there regularly try and you can contact them because they know what's going on. All the jobs come to them from all the wards, then they get allocated to you. So if you get an idea of how busy things are, you can then kind of plan your breaks accordingly as well. Another very important thing, and the last point I'll tell you is, okay, you've got the water, you've got certain things to help you nap, you've got your food, but a paper and a pen are very, very useful. So any jobs that come through, you'll get maybe multiple jobs in 5 minutes and then nothing for a couple of hours. But if you have a paper and a pen, you'll know what you need to get done. You'll know what you've not done and what you need to hand over. And say, for example, somebody told you about somebody's bloods that needs chasing, you can write down the ward, you can write down the name, and you can remind yourself that you need to chase these. So even if you do have an app or you are really busy, you won't forget anything. So I think those are my top tips, and I wish you all the best. Thank you very much. Let me see. Okay, I will stop this now.
All right, that's fantastic. Thank you so much, Mittal, for that fantastic talk on surviving night shifts. Really, really useful and practical advice. We're going to take a bit of a lunch break now. So we'll be back at around 1:30 for my next talk on sleep disorders. I hope to see you then. All right, and we are back. Hope you had a good lunch break, and if you have any questions as to the previous topics that have been discussed, put it down on the Slack. Hope you really enjoyed the last few talks, particularly enjoyed Ashish Bhatia's live consultation with a patient. I thought it was brilliant. So for the next half an hour, I'm going to be going through some sleep disorders. And sleep medicine as a whole is a really interesting specialty because it kind of stands at the intersection of psychiatry, neurology, and respiratory medicine. So it's a multidisciplinary field, really. So as per usual, continue to tweet about our webinar using the hashtag Medics.Sleep. And if you have any questions for me, there is my handle. Before we start, I just thought we could begin with a Mentimeter. So if you could use the QR code, just wanted to find out how many sleep disorders you guys can name. Okay, has everyone got this QR code? I'll just move over to this. So we've got insomnia, sleep apnea, good. Any other sleep disorders that we can name? Restless leg syndrome, good. PSO, OSA, OSA, okay, that makes more sense. Somnambulism, great. Bruxism, really good, affects children a lot. Parasomnias. Narcolepsy. Good, this is the sort of stuff that we're going to be tackling today. So let's get back onto the presentation. So great. So the overview of my presentation, I'm going to be going through the common disorders, some of which you've already named, like sleep apnea, restless leg syndrome, and parasomnias. I'm then going to go on to the relationship between sleep and the neurodegenerative conditions, touching a little bit about sleep and mental health. And finally, I'm going to end on the uncommon and rare sleep disorders, the weird and the wonderful, basically. And you can see at the bottom of my screen, I've got common, neuro, psych, and rare, and they're going to be highlighted dependent on which section we are on today. This section is going to be primarily for medical students. So if you are applying for medicine, there might be some parts of it that might go a little bit above your head, but don't worry about it too much. I'm sure you'll still be able to get something out of it. So the first condition I wanted to talk about was sleep apnea. And specifically, I'm talking about obstructive sleep apnea. And typically, the patient will come in with their sleeping partner, and their sleeping partner will say, well, I've noticed that he occasionally kind of stops breathing in the middle of the night, only for a few minutes, and it's never too bad, but then he gets back to his normal sleep. And that's the sort of thing that you'll hear. And you've got to look out for the sort of risk factors for sleep apnea. And if you look at the chap on the right-hand side of the screen, he perfectly exemplifies this. He's male, he's got a large neck, he's obese, he smokes a lot, he drinks a lot. Those are the classic risk factors for obstructive sleep apnea. And then you want to take a little bit more of a history from this. So obviously they will probably say that they've had these periods of time where they stop breathing for a little bit, but you also might want to ask about snoring and whether they get morning headaches, because if you're not breathing in the middle of the night, your quality of sleep is not going to be that good. So as a result, the patient may actually have some daytime sleepiness as well, and they will have some concentration problems as well. These last two are really important to discuss because they'll have quite a big impact on the patient's social life and their work life. And if you do come across a confirmed diagnosis of obstructive sleep apnea, you may need to inform the DVLA. So those are the sorts of risk factors and features of obstructive sleep apnea. In terms of investigating it, you do the sorts of sleep studies which Rita has touched on before, so taking those sort of vital signs as the patient sleeps. And in terms of managing the condition, at first, if it's a mild obstructive sleep apnea, you can advise lifestyle changes, correcting those reversible risk factors, so reducing weight, getting the patient to stop smoking. And another really important lifestyle change is getting them to change their way they sleep. Most importantly, if it's obstructive sleep apnea, advise the patient to sleep on their side as opposed to sleeping on their back, because this reduces the risk of these pharyngeal airways collapsing. In more serious cases of obstructive sleep apnea, you may want to consider continuous positive airway pressure. This is when positive air is pumped through the airways to maintain the patency of breathing. It's really important that you tell your patient how significant treatment is, because the thing is about obstructive sleep apnea is that it generally increases your cardiovascular risk. It will lead to a greater risk of high blood pressure, hypertension, heart attacks, myocardial infarctions, and stroke. And as well as that, poor sleep has a big impact on mental health. They're more at risk of developing depression. And if they're not concentrating as well, they could get into things like car accidents. So really important to treat. Now, I want to delineate this obstructive sleep apnea as opposed to central sleep apnea. And obstructive sleep apnea, as we described before, is a problem with the airways. Central sleep apnea is a problem in the brain. It is a problem in the way in which the brain controls the autonomic control of breathing during sleep. Now, you might be wondering why I've got this painting here. Central sleep apnea is also known as Ondine's curse, and this is a painting of Ondine, who was a character in a French play at the beginning of the 20th century. She was a water nymph who fell in love with a mortal man, and the man cheated on her. So to get her revenge back, she put a curse on this man that whenever he would fall asleep, he would stop breathing. So that tells you exactly the story of, might help you remember what central sleep apnea or Ondine's curse is all about. Central sleep apnea is considerably rarer than obstructive sleep apnea, so you're unlikely to see it, but it is an interesting aside nevertheless. So we've covered sleep apnea. Let's move on to restless leg syndrome, another condition you guys mentioned. So restless leg syndrome is this kind of uncomfortability and irresistible urge to move your legs, and it can really affect your ability to fall asleep because you just generally feel uncomfortable as you're in bed. And I would advise you to actually call it Willis-Ekbom syndrome as opposed to RLS. And there are two reasons for that. One, because the unpleasant sensations, they're not necessarily always in the patient's leg. Sometimes they feel it in their arm, sometimes they just generally kind of feel it in their body. So it's a little bit more accurate. And secondly, some patients feel as though the term restless leg syndrome has been trivialized a little bit in the media, and doctors don't take them as seriously. So try to move away from the term restless leg syndrome towards Willis-Ekbom. We can generally divide the condition into primary or secondary, and primary is basically when they have a family history of the phenomenon and there isn't a kind of underlying cause that we can identify. Secondary restless leg syndrome is when there is an underlying medical cause, and it typically comes around in the patient's middle-aged and they won't have a family history of this. So the causes of secondary RLS are most commonly, it is iron deficiency, but there are other causes like kidney disease and Parkinson's, and it is noted that there is an increased prevalence of RLS in pregnancy as well. The management of this condition is, again, fairly conservative. So think about advising your patients on improving those sleeping habits, the same sort of stuff that Caitlin was talking about in her first lecture. think about that sleep acronym and how you can get your patient to improve their sleep environment, all the motivational interviewing stuff that we picked up from Dr. Ashish Bhatia, and then also getting them to reduce their risk factors, get them to stop smoking, get them to exercise, and if it is a case of secondary restless leg syndrome, treat the underlying cause. Now, the third most common sleep disorder is the parasomnias. And parasomnia basically means an abnormal sleeping behavior. Now, actually, individually, parasomnias can be quite uncommon. They can be quite rare. But overall, collectively, these constellation of symptoms, once you put them all together, they're actually quite common. So we can generally divide parasomnias up into non-REM sleep and REM sleep, and also some that don't really fit into either. So if you remember back, these are the different phases of sleep. The non-REM sleep parasomnias have already been touched on by Rita, but there are a few that I wanted to just talk about a bit. Sexsomnia is quite a serious parasomnia, and there have been cases of the legal implication because the patient there have been cases of patients sexually assaulting people in the middle of their sleep. So it is one to know about. In REM behavioral disorder, in REM parasomnia, so that affects when there isn't that muscle atonia, the most important one you need to know about is RBD, and that stands for REM behavioral disorder. So REM behavioral disorder is essentially when the patient acts out their dreams, and it's typically that their dreams are getting a little bit more violent and a little bit more aggressive. And typically RBD, or REM behavioral disorder, is associated with Parkinson's disease, and I'm gonna cover that in a little bit later. But another really important cause of RBD is antidepressants. So check whether the patient is on tricyclic antidepressants, SSRIs, SNRIs, as this can also trigger RBD as well. A few other parasomnias which don't really fit the bill. Exploding head syndrome is not as dramatic as it sounds. You actually get it in around like 10% of the population. It's basically a sort of a weird, strange noise as people are trying to, as the patient is trying to fall asleep. And it's not exactly harmful at all. It can be a little bit scary, and it just requires a little bit of assurance. It's quite common that people have this. Somniloquy means sleep talking. And some people can get hallucinations, and that can be a sign of narcolepsy, which I'll touch on later on. So as you can see, really diverse constellation of symptoms and parasomnias, but collectively they are common. All right, so I've talked a lot about common sleep disorders. Let's do some questions. So here we have a case. A patient and his partner attend your GP practice. The patient is male, has a noticeably large neck, and is overweight. His partner states that he's become more sleepy recently during the day. At night, it seems as though he's stopped breathing. What is the most likely diagnosis? Let's see what you guys are saying. Good stuff. So most of you have put down obstructive sleep apnea. That is the correct answer. Just thought we'd start with an easy one. Okay, next question. So we actually have exactly the same case, but the question is, given the diagnosis, what lifestyle measures would you recommend? Just need to wait for it to show up on the Slack. Yeah, fantastic. The answer is sleeping on his side. That is the way to reduce the risk of those pharyngeal collapses. Third, slightly harder question, requires a little bit of medical knowledge, but the case is a 64-year-old patient presents to your sleep disorder clinic stating that in the past few months, he has an unpleasant sensation in his legs before he falls asleep. He often feels as though he needs to kick about in order to relieve these symptoms, but none of his family have ever had this problem. Given the diagnosis, what would you most likely find on examination? So the question, why does sleeping on the side help? It reduces the risk of the airways collapsing. So if you sleep on your back, it's more likely that the airways collapse. And that's the real problem with obstructive sleep apnea. I don't know if there is a specific side that's best, but I think the general advice is just sleeping on one side. Okay, fewer people answering this one, but you've all got the correct answer. It is koilonychia. So I'm just going to go through the case. So this is a case of restless leg syndrome or Willis-Ekbom syndrome. And the fact that it's a middle-aged patient and has no family history of the condition, more likely to think that this might be secondary cause of Willis-Ekbom. And the most common cause of secondary Willis-Ekbom is iron deficiency. And a sign of iron deficiency is koilonychia, that is spooning of the nails. And all the other signs are of different diseases, so spider nevi, of liver disease, splinter hemorrhages, of infective endocarditis, calcinosis of systemic sclerosis, and Kaiser-Fleischer rings is a sign of Wilson's disease, a copper metabolism disorder. All right, so back to the main show. We've moved past those common disorders. Let's talk a little bit about the relationship between neurodegenerative disorders and sleep. First one we're going to talk about is Alzheimer's disease. And I'm sure you're all aware of what Alzheimer's disease is. It's a degenerative brain disorder that affects your cognition, your memory, your thoughts, your emotions, your language, and your everyday functionality. And Alzheimer's disease is caused by the development of neurofibrillary plaques, neurofibrillary tangles, and senile plaques, which act as blockers in the brain's neurons, and that generally affects the function of the brain, and as a result it shrinks a little bit. So the relationship between sleep and Alzheimer's is a little bit complicated, but you can generally divide it up into, well, is the patient in the early phase of Alzheimer's, or has their Alzheimer's progressed a little bit more? And in early Alzheimer's, patients tend to sleep generally a lot more, but they wake up very disorientated. If the Alzheimer's disease has progressed quite a lot further, they tend to doze quite irregularly, rarely sleeping for long periods of time, waking up in the middle of the day, waking up in the middle of the night. So, and that has a really big impact on the patient's cognition and their sort of general, because it exacerbates the confusion and agitation of the patient. And the last thing I wanted to talk about in Alzheimer's disease is a phenomenon of sundowning, which you might have heard of. And this is quite interesting. And it's basically, it states that as the day comes towards an end, towards the evening, Alzheimer's patients generally get a lot more agitated compared to the morning and the middle of the day. And the reason why this happened, it's theorized that those plaques and tangles, those pathologic features of Alzheimer's disease, actually get stuck in the suprachiasmatic nucleus of the brain. And if you remember from Dr. Gavrilov's talk at the beginning, the suprachiasmatic nucleus, it lies just above the optic chiasm, and it takes all those light and dark cues from our external environment and feeds it to our biological clock, our circadian rhythm, telling us when we should fall asleep. And the dysregulation of that, the disruption that those plaques and tangles cause, mean that Alzheimer's disease patients with Alzheimer's disease tend to get more agitated in the evening. The relationship between sleep and Parkinson's is a bit of a complex one as well. And most people think of Parkinson's disease as purely a motor disease, those sort of tremor and rigidity. There's a lot more to it than that. And neuropsychiatric symptoms are often overlooked, and especially sleep problems. So we can, in terms of those that affect the ability to fall asleep, a lot of Parkinson's patients complain that they find it difficult getting to sleep. A really, really common feature of Parkinson's is nocturia, so urination in the middle of the night, and that disrupts sleep as well. And we touched on restless leg syndrome before, as Parkinson's can be a secondary cause. Remember also that the rigidity associated with Parkinson's can affect the patient's ability to sleep. If you're a lot more rigid, it's difficult to turn over in the middle of the night. And as well as that, Parkinson's patients are on drugs that affect dopamine metabolism, and their side effects can cause movement disorders, which can mimic some of the things like restless leg syndrome. That has a big impact on sleep and their quality of life. But the classic thing about sleep problems in Parkinson's patients is the REM behavioral disorder. So that was RBD, which I mentioned before, in the parasomnias. REM behavioral disorders is when the patients acts out their dreams, and typically a patient will come in with their sleeping partner, and their sleeping partner will say, well, I have to build a like a fort between myself and my sleeping partner of pillows, just so I don't get hit, because Parkinson's patients, when they develop RBD, their dreams get a lot more aggressive. They sometimes get violent, and they sort of lash out in the middle of the night. So it can be really distressing for their sleeping partner as well as the patient themselves. So a little bit about sleep and mental health, and this is a really important subject that I wish I could be able to talk about a little bit more, but I can't. If there's one thing to take away in any case of mental health problems, always ask about sleep, because sleep will be affected. It is estimated that 3 out of 4 depressed patients will have insomnia. It's a core feature of depression. And as well as that, in younger patients, it's noted that a lot of them get hypersomnolence, meaning that they sleep actually more in the middle of the day. And generally, this really can mess up their circadian rhythm and their ability to fall asleep in the middle of the night, in the evenings. So something that Dr. Gavriloff touched on a little bit are the drives to sleep. And there are 2 main different types of drive to sleep. The circadian drive to sleep, so that's our inborn biological clock telling us when it is the evening and when it is time for us to sleep. But there's also this homeostatic drive to sleep. And that is the kind of our body telling us that we need to replenish the sources. We need to heal ourselves. And that kind of deep, slow wave stage 3 sleep happens when there is a proper homeostatic drive to sleep. The reason why I'm telling you this is because in depression, there is a reduced homeostatic drive to sleep. And as a result, patients with depression don't tend to get that nourishing 3rd stage of sleep. So I've got a hypnogram for you here. And on the top hypnogram, that is of a patient who has normal sleep, and the bottom hypnogram is with a patient with depression. And if we look at the y-axis, it says awake, movement, REM, stage 1, 2, 3. Have a look at stage 3 on the top hypnogram. You can see that there are actually many hits of that stage 3 sleep. The patient is getting into stage 3 sleep quite a lot. And as a result, they're getting that really nourishing sleep. The body is healing itself. Now take a look at the bottom hypnogram. Stage 3 sleep is not really being hit that much at all. The patient isn't getting into the nourishing 3rd stage of sleep. So as a result, they get lower quality of sleep, and that can really have a big impact on their quality of life and their everyday functioning. And we know that if you put patients on antidepressants, this can reverse that, so their hypnogram can get back to that original ability to undergo slow wave sleep. Really important to ask about sleep in depression. And in anxiety disorders, this can affect sleep as well. So in general, the most common sleep problems occur in panic disorder and OCD. And in panic disorders, they get the patients get panic attacks in the middle of the night, and that can disrupt their sleep. And in OCD, it is the case that the rituals and compulsions disrupt the ability to maintain sleep in the evening and the night. Okay, so let's go back and do some questions and make this a little bit more interactive. So how does Alzheimer's affect sleep? One person brave enough to put 5. Or E. Oh, no, we've got more. It could be wrong. I don't know why you're all putting E down. Could be wrong, but it is not. It is correct. Well done. Oh, someone fell for it and put REM behavioral disorders. Well, you're wrong. No, the answer is that in early Alzheimer's disease, a patient tends to sleep a lot longer, but they wake up disorientated. And in late Alzheimer's disease, there's this irregular dosing pattern. A case. So a 68-year-old man presents to your GP practice because his partner complains about his sleeping habits. He states that his dreams have become more aggressive recently and he unknowingly acts out his dreams. You notice that while he talks, his right hand appears to be shaking moderately. Given the diagnosis, what other features may arise? Kind of a multi-step question here. Going to wait for a few more responses. Okay, so there seems to be a lot of people putting down A, which is confusion, urinary incontinence, and imbalance. A lot of people are, well, some people are also putting rigidity, bradykinesia, and postural instability. The answer is actually D, rigidity, bradykinesia, and postural instability. So let's look through the case. So the case is of a man who has REM behavioral disorder because he is acting out his dreams and his dreams have become more aggressive. And REM behavioral disorder is associated mainly with two things, either antidepressant use or Parkinson's disease. And you have a clue that it is more likely to be Parkinson's disease because the right hand appears to be shaking as well. Now, I do understand why you probably put urinary incontinence because I have noticed, I told you that nocturia is a feature of Parkinson's disease, but the most accurate other features of Parkinson's disease are the motor rigidity, bradykinesia, which is slow movements, and postural instability, which is falling over a lot. So D is the answer. So A, confusion, incontinence, and balance, that was actually in reference to a different condition, that is normal pressure hydrocephalus. Another way of focusing that is it's wibbly, wobbly, and wet. B is stroke. C is increased cranial pressure, like a brain tumor, and E is Alzheimer's disease. A little bit of a more difficult one. Okay, so the last few bits I'm going to be talking about the more uncommon and rarer sleep disorders. First one, a really important one to know about is narcolepsy. Now you probably know what narcolepsy is, and you probably have heard about it, and you probably think, oh, it's when people are just sort of fall asleep randomly. They're talking, they're driving, they're eating, and they just fall asleep like that. And yes, that is true. That is one of the features called excessive daytime sleepiness. But it is one of 4 features of narcolepsy. The others are hypnagogic hallucinations. So hypnagogic means as you're falling asleep, you have visual or audible hallucinations. Third is sleep paralysis. So as they are either awaking or falling asleep, they can't move at all. They are in complete motor paralysis. And the 4th symptom of narcolepsy, which is a really interesting one, is called cataplexy. And cataplexy is when the patient has sudden loss of muscle tone, and it depends on what type. It can be just on the side of a face, or it can be complete muscle tone, falling to the floor, collapse just like that, triggered by emotion. So the patient will be shocked or surprised, or they'll laugh too much and then they'll just fall to the floor. And that is basically a result of the mechanisms of REM sleep, the muscle atonia, the loss of muscle tone that you get in your deep sleep, intruding into wakefulness and being set off by emotion, stark emotion. And that's a result of a hormone called hypocretin 1 or orexin, which I think Dr. Gavriloff talked about before. So, a few other really rare conditions. Klein-Levin syndrome is also known as sleeping beauty syndrome. And it occurs in sort of teens and young girls, and it's very, very rare, but it's basically patients who are sleeping for around 20 to 23 hours per day, and there have been even cases of patients who sleep for weeks upon end, and when they are awake they have this sort of hypersexuality and eating disorder type behavior where they just want to consume everything. It is extremely rare. And the last really rare condition I wanted to talk about was fatal familial insomnia. And if you are interested in this, I've just put a QR code on the right-hand side of the screen because there is some interesting literature about it. But it's a really, really sad condition. It's basically this progressive worsening inability to sleep. Imagine one night you find it really hard to get to sleep, and the night after you find it even more difficult, and you're just getting worse and worse quality of sleep. And then all of a sudden your body just breaks down. You have autonomic dysfunction, dementia, double vision. You can't coordinate yourself. It's a really, really debilitating and sad condition. And very, very sadly, very unfortunately, these patients do not last long. As their symptoms start, they only tend to last around 18 months. So on that somber note, I'd like to thank you so much for listening. I hope you enjoyed that presentation. As per usual, tweet at us using the hashtag #MedicsSleep, and there's my handle as well. Let's move on. We have a little bit of a break at the moment. So feel free to grab a drink, chat on the Slack, and we'll be back at I think it's 20 to 20 past for Sarah Imani's talk on sleep and skin. It's 20 minutes, so yeah, 25 past.
All right, I'm hoping that everyone's back now. Can everyone hear me as well? Just check the Slack channel to see if you can hear me. Okay, I'm going to make a start. Good afternoon, everyone. Thank you to all of our speakers so far for their very insightful and interesting talks. I hope that you've all enjoyed them. I'm Sarah, I'm a fourth year medical student at the University of Leeds. Today, Dr. Soma and I will be going through the effects of sleep on the skin. I'll be covering a lot of new content, so please feel free to ask any questions that you might have in our Slack channel. So today I will be covering the anatomy of the skin, the mechanisms of skin-related sleep disturbance, common skin conditions associated with sleep disturbance, including eczema, psoriasis, urticaria, and rosacea. Then I will be going through the management of sleep disturbance in dermatology, and finally finishing off with a couple of recommendations. And after that, I will hand over to Dr. Soma. Also, if you have any questions, you can also contact me directly on my Twitter, Sarah Masul, or DM me on my Instagram, The Persian Medic. Okay, so before we begin, I am going to test you a little. Let's revise the anatomy of the skin. So what are the layers of the skin, going superficially to deep? So from the top to the deeper layers of the skin. You can answer that on the Slack channel. Let's see. Okay, got some answers, keep them coming. Can we get a few more? So going superficially to deep. The top of the skin to the deeper layers. Any more? Okay. Let's go back. All right, so as most of you guessed it, the right answer is A. So the skin has three main layers. The epidermis, the outermost layer of the skin, provides a waterproof barrier and creates our skin tone. You can actually remember the 5 sublayers of the epidermis using "Come, let's get some beer." So you have the stratum corneum, the stratum lucidum, the stratum granulosum, spinosum, and basale. Then underneath that, we have the dermis, and it contains tough connective tissue, hair follicles, and sweat glands. And then deeper to that, we have the subcut tissue, otherwise known as the hypodermis, and that is essentially made up of fat and connective tissue. So the skin is the largest organ of the body with a total area of about 20 square feet. The skin actually protects us from microbes and the elements, helps us to regulate our body temperature, and permits sensations of touch, heat, and the cold. Sleep deprivation has been shown to have detrimental effects on behavioral, physiological, and psychological functioning. And skin disorders are variably associated with sleep disturbance and sleep deprivation. And actually some have been associated with specific disorders such as obstructive sleep apnea as well. So
One of the cardinal symptoms of a number of dermatological and systemic disease is pruritus. Pruritus is just the medical term for itch. Patients suffering from inflammatory skin conditions, including atopic dermatitis, psoriasis, lichen planus, and chronic idiopathic urticaria, have reported an increase in itch during the night. So this really begs the question of what are the possible pathophysiological mechanisms of itch-related sleep disturbance? So the first itch or skin-related cause of sleep disturbance is skin temperature changes. As you can see from this graph, and by the way, distal and proximal are just anatomical terms. Distal means body parts situated away from the center of the body, like our fingers and toes, and proximal means situated nearer to the center of our body, like the trunk or the abdomen. So distal skin temperature actually increases during the night and is lowest in the morning. This results in an increase of transepidermal water loss at night. And transepidermal water loss is just the amount of water that's lost through our pores of our skin. And this is associated with itch intensity in patients with eczema and damage to the stratum corneum, so the top layer of the skin. This then compromises the epidermal barrier function of the skin, allowing irritants closer to itch-sensitive areas. Nocturnal sweating, sweating due to exercise, stress, ambient heat can also increase itch, therefore disturbing and disrupting an individual's sleep. So Dr. Gavriloff has already touched on the circadian rhythm, but I'll be talking about it more in terms of how it relates to the skin. So the circadian rhythm is reflected in all cells of the body to optimize cellular function and meet environmental changes associated with light. Although the central master clock for the circadian rhythm is primarily by light entering the retina and stimulating the suprachiasmatic nucleus, the SCN, the skin as an organ is in a very unique position between the environment and the organism itself, both receiving and generating signals relating to timing. As you can see in this picture, in this image, the master clock and the SCN communicates timing information to the skin via a combination of sympathetic nerves and hormones. And as I said, the skin is directly exposed to external conditions like temperature, light, humidity, UV radiation, and pathogens. And under normal healthy conditions, many attributes of human skin are cyclic, including its hydration, capillary blood flow, sebum production, temperature, surface pH, and proliferation rates. Okay. And another aspect of our circadian rhythm is our central stress response system, the hypothalamic pituitary adrenal axis, the HPA, which secretes corticosteroids in a circadian rhythm. Levels are actually at their lowest a few hours after the commencement of sleep, where anti-inflammatory effects of corticosteroids are also at their lowest at this point, actually. So this could allow for many exacerbations of inflammatory skin disorders, thereby increasing nocturnal itch. Furthermore, the subnormal cellular cyclic AMP levels allow greater secretion of cytokines, causing nocturnal histamine release and increasing itching, which would then again interrupt sleep. Okay. Nocturnal awakenings associated with itch are generally thought to have a medical rather than psychological cause. However, it is important to appreciate possible psychogenic causes of sleep disturbance in patients with pruritic skin disease. For example, stress, anxiety, and increased depression reportedly enhance itch perception. Pruritus and chronic skin diseases are often associated with low mood and depression, which themselves are associated with disrupted sleep patterns. So it kind of leads to a very vicious cycle. And due to the complex interactions of pain and pruritus, it's plausible that reduced psychological stimulation in the evenings may actually in turn exacerbate itch. Okay, so we've been talking a lot about pruritus, so you too might be itching to know why we actually itch and what causes it. The itch scratch cycle helps us to understand this mechanism a lot better. So we first begin by this step. Scratching an itch causes and it releases pruritic mediators within the skin. And this in turn, because of the damage to the stratum corneum, also allows closer association of antigens with the skin. The end result is really a self-perpetuating and debilitating routine, the itch scratch cycle. In chronic pruritic skin conditions, scratching can become habitual. So it's a very subconscious and automatic behavior acquired through repetition, actually. So consequently, anything that promotes nocturnal scratching, as discussed above, is likely to initiate or perpetuate the itch scratch cycle. All right, so now I will move on to discussing some chronic and commonly seen conditions in derm and GP that are affected by sleep. The first one is eczema, also known as atopic dermatitis. This condition affects a staggering 17% of children and 2 to 3% of adults. It is the chronic pruritic inflammation of the dermis and epidermis. There is a strong genetic component associated with eczema, and it's also associated with asthma, allergic rhinitis, and conjunctivitis as well. Disturbed sleep is a common complaint from both the parents of children with eczema and adults that are commonly affected themselves. And 60% of parents have reported that dermatitis affected how well they or their children slept. Adult patients with AD are known to sleep less, awaken more often, and for longer, resulting in overall reduced sleep efficiency. And this in turn can have significant effects on behavior, physiology, and psychological health, adding to the disease burden, unfortunately. Okay, so now moving on to psoriasis. Psoriasis is essentially an inflammatory skin condition that affects 1 to 3% of the population. It is characterized by sharply demarcated, as you can see in this picture right here, sharply demarcated scaly erythematous plaques in fairer skin. And in darker skin types, it presents like this. And it's commonly found on the scalp, elbows, knees, but can also present on the hands, feet, and the trunk. And the nails actually show this characteristic pitting, which you might already be aware of. Psoriasis can be triggered by several factors, such as injury to the skin, and this is known as the Koepner phenomenon. Infections such as HIV and drugs also. Itching occurs in 64% to 84% of sufferers and is prolonged in the evenings or at night. And the physical impact of the disease heavily influences the psychosocial quality of life, with as many as 50% of patients reporting depression and anxiety. All right, now moving on to urticaria, otherwise known as hives. It's again a common derm problem, producing transient swellings as a result of plasma leakage. If this occurs in the upper part of the dermis, where itchy pink or pale swellings develop, it's known as wheals. But if it occurs deeper into the dermis, it is termed as angioedema. It occurs due to a vast array of cytokines and inflammatory mediators which are released and synthesized, producing localized inflammation and edema. The itching can actually lead to nocturnal awakenings and difficulty with sleep initiation itself. And a lack of sleep has been associated with reduced quality of life for these patients whose energy levels, work life, social interactions, home care, personal care, and relationships can all be affected. Finally, we have rosacea, and rosacea is a common condition again that causes redness and visible blood vessels in paler skin types. It may also produce small red pus-filled bumps. These signs and symptoms may flare up for weeks to months and then go away for a while. Anything that causes your rosacea to flare up is actually called a trigger. Sunlight and hairspray are common rosacea triggers. Others include heat, stress, alcohol, and spicy foods. So we usually tell patients to steer away from these triggers. A study of 462 individuals revealed that 52% of patients with rosacea suffered with poor sleep. They also found that poor sleep might actually aggravate rosacea through regulating inflammatory factors, contributing to a vicious cycle again in the progression of the disease. All right, so a small number of skin conditions can result in sleep disordered breathing. One of them is lipodystrophy. And lipodystrophy is essentially a redistribution of fat tissue from extremities to the trunk, often to the upper parts of the chest and the back. There are many types of lipodystrophy. In familial partial lipodystrophy, after a normal childhood, there is symmetrical progressive loss of subcutaneous fat from the extremities and a compensatory accumulation of fat in the head and neck, resulting in a round phase and excess subclavicular fat, so right here, causing obstructive sleep apnea. All right. Now moving on to how we would essentially manage these derm conditions. With the exception of sleep disordered breathing arising directly as a result of a derm condition, any sleep disturbance associated with skin diseases discussed would be classified as insomnia due to a medical condition. With limited guidance for derms in managing sleep disorders, it's actually very useful to review the treatment modalities in insomnia in general and then apply those to the patient cases. Non-pharmacological interventions in the treatment of insomnia show reliable improvements in several sleep parameters and should be recommended, particularly in chronic conditions which bring with them degrees of depression, anxiety, and body image issues as well, actually. Cognitive behavioral therapy has been proven to be one of the best evidence-based and effective strategies in these situations as well. The only review published to date on the management of sleep in skin disorders specifically focused on atopic dermatitis, apart from recommending benzos, antidepressants. The author also suggested prescribing melatonin, although the usefulness of melatonin in sleep disorders actually still remains quite controversial. And to end this, a couple of recommendations. There's definitely, from the research that I did anyway, perhaps Dr. Soma can touch on this as well, there's definitely a lack of management guidelines for dealing with acute and chronic sleep disruption in DERM conditions. With the exception of obstructive sleep apnea linked to rare DERM disorders, reassuring the patient that sleep loss is a result of the skin condition is very important for their mental well-being. So as the condition improves, so should the sleep. Every effort should be made towards reinforcing sleep hygiene, addressing psychological issues, and recognizing the existence of depression and anxiety. And involving a sleep specialist, a psychologist or psychiatrist, as and when is hugely recommended. This can result in improvements in the skin condition and really enhance the patient's quality of life, which is of utmost importance. And that ends my presentation. Thank you so much for listening. If you do have any questions, pop them in the Slack channel and we can answer them in the Q&A. I will now hand over to Dr. Soma.
Hi, everyone. Hi, I'm Dr. Soma. I am doing this presentation on skin and sleep, beauty sleep. So I am a dermatology registrar in London, and I also run the Instagram account, Dr. Soma Skin. So if you're interested in beauty and evidence for kind of skin related content, please have a look. I'm also doing a master's in skin aging and aesthetics at the University of Manchester. So I have a special interest in skin aging, and I'm going to talk about that in the context of sleep today. So going on to the next slide, the table of contents. So I'll tell you a little bit about what happens to our skin when we sleep. I know that's been covered in the lecture a little bit right before this. I'll also talk to you about wrinkles in sleep and the mechanistic forces that happen during the night that contribute to wrinkle formation. I'll talk to you about perceptions of our appearance when it comes to sleep deprivation. And finally, I'll tell you about some skincare tips, some beauty tips that are evidence-based about treatment with sleep deprivation and skin. So let's start by the next slide, skin and sleep. So beauty sleep is a concept that I'm sure you guys have heard many times, but is it just an old wives' tale, or is there any truth to what it actually means? We know for a fact that sleep is connected to both skin disease and skin aging through a variety of factors. And so I'll touch a little bit about collagen production, melatonin, and what happens in sleep deprivation. So the physiological processes that occur during the night that contribute to beauty include the formation and growth of collagen. So for those of you who aren't familiar, collagen is a structural protein that's found in the deep layer of our skin, which is called the dermis, and it's found within the extracellular matrix, which is kind of this pool, this kind of like gelatinous pool that has cords in it that support our skin, and those cords are the collagen and the elastin, and it gives our skin this like bouncy, youthful quality. And so during sleep, our body releases human growth hormone, which is a necessary ingredient for collagen production. Then melatonin, which you've probably talked about today, is known for its contribution in circadian rhythm, but actually it's also a really powerful antioxidant. So you may have heard the term antioxidant talked about in skincare a lot, but what does it mean? So as part of normal cellular metabolism, we produce reactive oxygen species, which can be highly toxic. And these reactive oxygen species, these free radicals that can damage our tissue, well, we have antioxidants that kind of fight against them and create this balance. But sometimes the balance is overwhelmed when you have too many free radicals, and then that can degrade collagen and elastin and damage your tissue. So you want to make sure you have enough antioxidant defense to help against the free radicals. And melatonin is a really powerful antioxidant. So when you sleep, when you generate melatonin, it can help with all the reactive oxygen species that have been generated and prevent what is known as oxidative stress on your skin. So what happens when you're deprived of sleep and you're not getting enough sleep? So lack of sleep causes the stress hormone cortisol to be released, and that triggers an inflammatory pathway, which, as you've heard before, causes all sorts of skin flare-ups and conditions like acne, psoriasis, and eczema. But it can also affect kind of, you know, cosmetic things in your skin. So when cortisol levels rise, you also get changes in salt balance in your body, and you can retain water. And this water can be retained in the areas periorbitally. So you can get things like eye bags or eye puffiness, which are kind of associated with looking tired or looking older. What we also know is that lack of sleep can definitely decrease your barrier function. So your skin has many roles, one of it which is to be a barrier and prevent you from losing valuable things through the surface, as well as prevent harmful things from entering. And one of the things that it prevents you from losing a lot of is the water that you have in your skin to keep it hydrated. And when your skin barrier is porous and not working well, then you can get increased transepidermal water loss. So that's TEWL. And if you're losing lots of water because your barrier isn't intact, then your skin is going to be dry, dehydrated, and just not look, you know, shiny and bouncy. So that can contribute to making you look old and tired. So those are kind of the physiological processes that can occur to affect your beauty sleep. So if we go to the next slide, I now will tell you some of the mechanical processes that can happen during the night. So I want to talk to you a little bit about wrinkles and what causes wrinkles. And wrinkles, the cause of wrinkles is multifactorial, but wrinkles tend to happen in areas where you have repeated muscle contraction. So you'll see that people get them at their like smile lines, or the crow's feet, which are the lateral eyes where you kind of crinkle when you smile, or when you frown, you get kind of a furrowed brow. So you tend to over time develop wrinkles where you have repeated muscle contraction. And the reason why those wrinkles over time become permanent is because you lose collagen and elastin, so your skin is less able to bounce back, and those repeated contractions kind of permanently affect your skin. But researchers have found that you can also get something called sleep wrinkles, and those are wrinkles in areas that aren't where muscle is contracting, but rather where there's strain, particularly on your face when you're lying down sleeping. And if you consider how many hours you might be spending in that position, then you can imagine that over time, the accumulation there is of repetitive kind of wrinkles in areas of kind of strained pressure. So what we know is that the number of positions that you sleep in throughout the night are on average around 27. So that's you tossing and turning throughout the night. But as you get older, that number almost halves and goes down to around 16. So you're spending much more time in a single position. And so that means the more time you spend in a position, the more kind of shear forces and positional forces you have against your face that can contribute to those wrinkles. And the lateral sleep position, the one on your side, is the most common. So around 60% of people sleep on their side. And so sleeping on your side or sleeping on your face are the ones where you're most likely to develop these sleep wrinkles. And they're a product of the kind of shear that you get from going up and down against the pillow or the bed, and then compression of your face against, and then the tensile force. So if we go to the next slide, you'll see how this is depicted. You can see the kind of shearing that happens back and forth, and then the tension and compression of your head against the mattress. And this is what contributes over, you know, we're talking about like decades, but you can also see kind of a temporary effect. Just when you wake up in the morning, you'll sometimes see creases in your face from sheets or from pressure. And those you bounce back from, but over time, as your collagen breaks down and you're not repairing your skin as well, and your skin is more dehydrated, then it can be more permanent. So if we go to the slide after that, you will have a look at the types of wrinkles that are common sleep wrinkles. So they're much more lateral, different from the ones that I described to you about the muscle contraction wrinkles. So you're getting kind of your forehead, it's kind of like a smushing of your face, I guess, against the pillow, and that kind of shift horizontally is where those wrinkles will be found around your cheek and eye. So we've talked about the physiological processes that can contribute to beauty, sleep, and then the mechanical forces. And then finally, I just want to talk to you about perceptions, which is the next slide. And what we know from research is that both others and yourself can perceive when you are sleep deprived, both short term, so as little as one night of poor sleep, to long term, so up to a week. So there have been studies where they've taken photographs of you fresh faced, and then they've taken photographs of you sleep deprived for a day or sleep deprived for a week or poor sleep. And then they've shown those photographs both to the participants and to assessors. And both parties have been accurately been able to determine which is the sleep deprived one. So without a doubt, we know that short-term sleep deprivation does alter changes in appearance that are perceived both by others and by yourself, and then consequently can affect your self-confidence. And the types of changes you see are things like bags under the eyes, things like dull, dry skin, wrinkle formation, and yeah, just general kind of puffiness and lack of glow. So those are the main characteristics that were identified. So what can you guys do to combat this, or what can you advise people who might ask you about this? So obviously, if you're general doctors, this might not come up, but if you're a GP, you never know, that might be a question, or friends and family might ask, or if you go into dermatology or aesthetic medicine, these might be things that come up. And it's good to just know about the processes. So the next slide, I can give you some tips about a beauty, sleep, skincare routine, and you'll know what the science behind these recommendations is, because there is science in aesthetic dermatology as well. So cleanse. So at the end of your day, you definitely want to wash your face, and that is, if you wear makeup or sunscreen, which you should be wearing, you want to get rid of all those things because they have ingredients in there that can be irritating to your skin, that can sort of impact your skin barrier, things that you don't want to have overnight unless you absolutely need to have them on your skin. So you're best just washing them off and starting with a fresh canvas. It also means that what you apply to your skin afterwards will be more likely to absorb and work properly. And if you're someone who doesn't wear makeup or sunscreen, just the impurities of the day, you know, your skin can absorb things on its surface, including pollution particles, different oils and grease from external factors. So really important to wash your face at the end of the day. And then you can move on to your next steps. The thing I've put here below is antioxidants. So antioxidants don't need to be put on at night. They can be put on during the day. It's just in order for you to make sure you have the right balance of antioxidants to fight the free radicals. And vitamin C serum is one of the most popular and proven antioxidant treatment. So vitamin C serum is something you can use during the day to sort of boost your antioxidant capacity, especially if you're sleep deprived. And then moisturize. So that can be part of your nighttime routine. So we talked about how lack of sleep can reduce the skin barrier's ability to retain water and hydration. So you want to be able to supplement that with a good moisturizer. So you should be using a nice moisturizer before you go to bed. Then I have here retinoids. So in terms of the evidence base for skincare ingredients, one of the most effective ones, well, sunscreen is the number one, but apart from sunscreen, the retinoid family, which is a class of topical treatments that are derived from vitamin A, those retinoids, specifically tretinoin, some of them they're photo unstable and can degrade in light. So you want to apply those at night before you go to bed. And what do retinoids do for your skin? They are one of the only things that can help stimulate collagen production and can actually reverse some of the signs of aging, like fine wrinkles. Most other skincare treatments are potentially protective and preventative, whereas this kind of has a rewinding the clock option as well, but it cannot be used in pregnancy. So that has to be used at night. So that could be part of your beauty nighttime routine. And then I have protect and position. So this is less evidence-based, but some people will say that using something like a silk pillowcase, you'll have less shearing forces against your face. So that can sort of maybe prevent some wrinkle formation or stress on your skin barrier. I've not seen any studies about this, but you can sort of extrapolate why that might be somewhat helpful. And then finally, position. So, you know, the most important thing is that you have a good night's sleep, because lack of sleep and sleep deprivation causes all sorts of stress to your skin. But if you were interested in a position that would be most beneficial, it would be sleeping on your back. And if you're someone who's prone to a lot of kind of puffy eyes or eye bags, then you want your head to be slightly elevated with a pillow or two to kind of help redistribute fluids and drain fluids and things like that. So those, I think, are the key elements that you can incorporate both in your day and night routine to help you get the most out of your beauty sleep. So that's it. The final slide is just thank you very much. I've got some references here of research. There's my Instagram handle if you guys want to follow me, and I'm happy to answer any questions about this or dermatology and skincare in general.
Thank you very much, Dr. Soma. I just realized I was muted. Thank you very much, Dr. Soma. Could all of our speakers show their faces, please? Fantastic. We're all back. We also have with us, we have Dr. Jane Hicks, who is a consultant psychiatrist and has a cat. And she is, well, Dr. Hicks, why don't you introduce yourself?
Oh, hi. Yes, sorry about the cat.
That's okay.
A brilliant day, Vinay. I've had my ear on nearly all the time.
Oh, fantastic.
And great that you've all done talks. That's great. I'm a consultant neuropsychiatrist interested in sleep for the last 25 years. Oh my goodness. I wrote a thesis on insomnia, and I've run a sleep clinic for quite a few of those years. So hopefully I can give you probably more of a clinical perspective, really. Yeah.
Mm-hmm. Fantastic. So over the past few weeks, we have been gathering quite a few questions from our followers on our social media. So we thought we'd ask a few of these questions to our experts. So since Dr. Hicks has just introduced us to herself, why don't we ask the first question? So we have had one question saying, we often talk about how we treat and help patients with sleep problems. How about us as students and doctors? I am a fourth-year student recently diagnosed with idiopathic hypersomnia, and the prospect of working as a doctor is quite daunting. Is there any advice that you can give?
Yeah, it's really a good question. I mean, I guess I'd need to know if you've seen a sleep specialist for that diagnosis, because that's really important, that they've ruled out narcolepsy, either type 1 or type 2. It sounds like you have from the way you've worded the question. And I think people need to recognise that this is a proper diagnosis. I think people with idiopathic hypersomnia get a bad deal, really, because they just say, oh, you're sleepy and you're a bit lazy and, you know, you don't really have narcolepsy. Well, you don't have narcolepsy. So, you know, what are you doing using it as an excuse for? But, you know, you can be quite sleepy, and on an MSLT, you will have you will fall asleep. It's about 8 minutes, I think. You'll, with respect to a person with narcolepsy, who will fall asleep in a couple of minutes on that test. That's the daytime test where we really measure in the laboratory how sleepy you are in 4 sessions. I think if I was going to be working as a doctor, I would probably be upfront about it and say I had that problem, and make sure your seniors knew. And particularly if you're working shifts, that's going to be quite complicated. And I would probably, if you can see a sleep specialist, if there's one in your area, then get some advice how to handle those shifts and your shift pattern. But, you know, be open about it so people don't get the wrong message, if you like.
Yeah, that's really good advice, especially with something so stigmatizing. Important to let people know so that they're aware and you can still work at your best function as a doctor. Caitlin, do you want to ask the next question for Dr. Bhatia?
Yeah, so we have two questions here that are fairly similar, so I'm going to merge them because they both tie into the same sort of theme. It's so what are the best tips for handling sleep problems when you feel stressed or overwhelmed, and how to switch off after a busy day, that sort of thing?
The first part is insight, which your question asker has already got. A lot of people are stressed and fatigued without even realizing it and can manifest it in other ways. So what I might suggest they're doing is they're already starting at a good place. My general philosophy is start where you are, choose what really matters, do what really helps, and relax. So they've already started where they are. The next thing is to choose what really matters. So actually addressing their stress might need to become a priority in their day. And so there are various ways of doing it. So understanding what the triggers might be really helpful. So keeping a little journal or talking to a friend who understands you. Forgiveness and understanding are naturally relieving. And recognizing we're living in an environment that generates a lot of stress, it's very different to what we've evolved to be in, can also allow quite a lot of compassion. One of the biggest parts that I find for people who see me as a GP or in my other practices is actually working with the body's rhythms. So one thing that the digital age doesn't necessarily allow is time for these ultradian rhythms. So they're rhythms within the 24-hour cycle where we actually need to pause and process. And when you've got these things or your beepers on, you're always on call. So there aren't those natural rhythms. So deliberately booking time blocks out to be able to pause and process, connecting with your body, connecting with nature, even practice some of those breathing techniques that Caitlin, you described, the box breathing. Just practice and give yourself a little bit of time to practice before the performance. Does really well. And if in doubt, then talk to someone. Part of our bread and butter in general practice is to be there, not just when you're poorly, but to promote your health. And so talking to a compassionate GP would be another step to go towards too.
Yeah, that's super helpful, because from the resources you had sent across, you had mentioned sort of time boxing in, time for relaxation in the night, and I found that was actually very, very helpful. And good to reiterate that, you know, if things are becoming a problem, go and see your GP and talk it through and get some help that way as well.
Rita, do you want to ask the next question? Obviously, Dr. Mittel-Mysore isn't here, unfortunately, but anyone can answer these questions.
So the question is, how do you manage lack of sleep when you have wacky shift patterns? Just an open question.
Well, I think the person who gave the shift talk could probably answer that, or is he not here? Is that the one you're saying?
Yeah, unfortunately, he's not here. Yeah.
Yeah. I thought he did an excellent talk, actually. Is there anything that wasn't covered in that for the person who asked this question?
I can tell you some tips that helped me with night shifts when I was doing them a lot as a junior doctor. What I found useful was I don't know if this is covered in this talk, unfortunately I couldn't be there earlier in the day, but I just reversed my habits completely. Breakfast, and then when I got back from a night shift in the morning, I would have dinner, and it just helped kind of associate my mind that it was a habit reversal.
One of the big challenges for shift work is also there are more than 2 shift patterns. Often there are earlies, lates, and night shifts. And one of the questions that I get asked quite a lot by shift workers and medics is how do I do that? And one of the key things that I've discovered is if you anchor your wake up times and only need to shift twice, then that can really alleviate some of the challenges of having 3 shift patterns to deal with. So kind of merging your earlies and your lates together, so you only have 1 wake up time but a longer day. It can help. So you've only got to make 2 time shifts over the course of that month.
Good tip.
But insight, recognizing that you are short slept is hard to do because you lack the insight when you're short slept.
Yeah.
So making sure that you're ultra careful, that you keep checklists. So someone said, write it down, and that way your brain won't have to ruminate, is also really, really, really good, as well as kind of listening to those other things he talked about, sleep patterning and eating and caffeine.
Brilliant. Those are some great tips. Thank you, guys.
Sarah, do you want to ask a question from the audience?
Of course. So Dr. Soma, you talked about puffiness under the eyes, but with dark under eye circles, would you say they're mostly sleep, a lack of sleep, or genetics? And do brightening ingredients like vitamin C or niacinamide actually help to brighten the under eyes?
Yeah, I get asked about dark circles a lot, and the cause of dark circles is multifactorial. So the thinnest skin in your body is periorbital, and so it's much more translucent, so you can see the structures underneath more easily. So a lot of times it's just vasculature that's creating a shadow, and as you get older and that skin becomes more thin, then it becomes more wrinkly. So the microscopic wrinkles cast a shadow on themselves because it's not a completely convex surface that can reflect light, but it has all these concavities in it. So these kind of hills and valleys that create the impression of shadow. And then they also tend to be genetic and run in families and are more common in certain skin types. So in terms of what works, there's not tons that you can do. So for the puffiness, yeah, it can be positional. You can help with some brightening ingredients like the ones that you mentioned, niacinamide, vitamin C. And a lot of times it's also that like makeup with reflective particles can be helpful, or some laser treatments, but those are obviously much more pricey.
Yeah, definitely. And at what age would you actually recommend, starting a night routine?
Oh, well, I think everyone has a skincare routine, even if your skincare routine is nothing, that's still your routine. So I think there's not a specific age. I think people should be looking after their skin as soon as they're adults and their parents aren't looking after it for them. So even if your routine is simple, like just water, then that's something. But I would say from the time you're a teenager and you have more specific skincare needs, maybe more acne related as your pores and your oil production change, then you probably need a routine refresh and more complicated things every 5 years after that, if you want to stay on top of anti-aging or pro-aging skincare.
Yeah, definitely. I agree. I feel like my skincare routine has definitely become more complex over time. So
yeah, exactly. Yeah. It plateaus, I think, at some point, probably at around your, postmenopausal skin, then there's probably a plateau as to what more you can add on top of just your basic stuff. But yeah, it continues to get complicated if you need, but the basics are the important thing.
Thank you.
Okay, so yeah, we have another question that was asked previously, and I think is also being asked in the chat. Is there any way to stop, I don't know, maybe Dr. Hicks can answer this. Is there any way to stop really vivid dreams, not necessarily nightmares or night terrors, but I have very realistic dreams. I often wake up feeling exhausted from dreaming so vividly and wondering if there's any way that I can change to simply sleep without dreaming. And I think the same person has added that they've recently had episodes of waking up screaming, believing that there is someone stood at the end of the bed, but they're not exactly paralyzed. And it seems to be having quite a big impact on them. I was wondering if you could possibly give some advice to this particular person.
I mean, I don't know whether it's vivid dreams or nightmares. We don't really have that detail, do we?
So the person actually says it's vivid dreams, but not necessarily nightmares, just very realistic dreams. And that sort of exhausts
I mean, being a psychiatrist, one wonders what else is going on in their lives, but there's not always a connection between dreams and stress, but there can be. So probably the person needs to look at that. I mean, I was thinking also about PTSD, and that would be obviously more of a nightmare content. It might really be, if they were looking for a medication option, then it might be worth trying a little bit of an SSRI just to see if that could calm their mood in the day. And also, obviously, that will actually decrease the REM sleep, although it's not a permanent decrease. It lasts about 3 months before it rebounds back, but sometimes that can break the cycle. And so if you've got less REM sleep, you'll have less dreams. That's the rationale behind it.
Okay. And as a psychiatrist, how much do you sort of look into dreams? I know sort of looking back in history, you have sort of Freud doing his dream analysis, his massive text on the interpretation of dreams. How relevant is that text to modern psychiatry, or should we just relegate it to history?
If you work in a busy community mental health team, unfortunately, it can't be very relevant because there's just not time to discuss it with patients. And that's a real shame. But usually the people we see will be having a PTSD dream problem with not nice content. I think that we don't know enough about dreams in general. I think, in daily clinical life, I'm afraid we probably don't address them enough, really, or what their content really means. So I'm being pragmatic here, really, I'm afraid.
Okay. All right. Caitlin, why don't you ask the next question?
There are some practical things that people can do with the daytime legacy of dreams. So not necessarily shifting them, stopping them from happening. But one of the issues could be, are they waking up while they're in a funny part of their sleep cycle? Are they being disturbed early? So they haven't they're still in the depths of, or in the heights of REM sleep. There's a great app that's free as well called CBTI Coach that is specifically designed for Marines who have gone through PTSD. And it gives a lot of techniques that can help someone unwind and process their thoughts before they go to bed. Because I thought, from my understanding, I bow to Dr. Hicks's greater knowledge, the emotional content of dreams do correlate to the intensity of REM sleep and the emotional experience, but not the actual physical content. Like if you're flying a car, not going to correlate. But the emotional content while you are flying the car is found to correlate to the daytime. So your daytime activities and how you process those emotions will impact on the emotional content of your dream.
Okay, so no need to look for symbolism or anything like that. All right, Caitlin.
Yeah, this is again for you, Dr. Badia, because this was a big question that came up actually after your talk. So I don't know how much time you will have had to prepare for this, but it's more sort of how much do you see motivation as the biggest factor in someone's changing their sleep, other than more practical issues like time available, young children, that kind of thing?
Yeah, motivation is a significant factor in my understanding. So that the people who I tend to come across, I describe them as having the P's and Q's of sleep issues. So there's an issue to do with their quality, quantity, their prioritization. You can over prioritize and develop insomnias, or you can under prioritize and just be unaware you're short slept, like 2/3 of the planet potentially are. And also their periodicity. Are they just desynchronizing their bodies and their mental processes? In terms of, sorry, I've gone off one and completely forgotten your question. Sorry.
It was essentially just saying they wanted to know, and I suppose it's probably quite anecdotally in your practice, but how much you see motivation as the main factor.
Motivation, fundamental in any kind of behavioural change. And I think I alluded to something called the tiny habits, which is a fog model for behaviours. And I've not come across something so effectively simple that I even go to primary schools and talk about it. And that's the equation, that behavior is effectively a function of our motivation, which is going to wane and it's going to go up and down. So you can't really rely on it. Your ability to do stuff, so how easy it is, and the prompt, the trigger. And when someone's come to see me, they're usually pretty motivated, but I know their motivation is going to wane as they go into the environment. So what I've discovered is, if you really make it so easy, it's unavoidable for them to make a small change and make it satisfying so they feel really successful, they'll get the positive feedback, which then, and they'll sleep better, so they'll then knock on to the more challenging habits. So motivation is definitely important, but I work on the lowest common denominator when I relate to motivation.
That's really great. Hopefully they've
Dr. Hicks, though, what's your experience with motivation?
I haven't really worked with it. I was really interested in your talk. I haven't really done very much on it. So no, I can't really comment any further.
Rita or Sarah, I don't know who wants to ask the next question.
Yeah, I can go next.
Yeah.
So Dr. Soma, someone has asked, in real practice, do you treat the itch or the psychological stress first?
Do I treat the itch or the psychological stress first? Are we talking about in the context of psychologically driven pruritus?
I
what we mean?
That's what they meant.
Pruritus is a very interesting dermatological condition, and there are a variety of factors. So the psychological is a diagnosis of exclusion. So you have to find out whether there's any other underlying cause, such as, hematological malignancy, iron deficiency, primary skin condition, et cetera. So you have to do like a battery of investigations. And then if what you conclude is that it's a psychologically motivated itch, then there are medications that are specifically targeted towards that. There's a specialty of dermatology called psychodermatology, and those are primary dermatologists that have training in psychiatric medications, and they are usually the ones that undertake, although sometimes dermatologists will prescribe some SSRIs, or I think naloxone is being used also for itch. So those are some options. So yeah, if you're convinced that the reason is psychological, then you have to also treat that cause. Otherwise, just treating the skin alone won't get you that far.
Okay, that makes a little sense. Thank you.
All right. Wanted to ask a question about the long-term effects of sleep deprivation in motherhood. I wonder if Dr. Hicks, you could answer that, because I know you've done some work in perinatal psychiatry.
Oh, sorry, the cat again. Well, we have been looking at using bright light therapy to help treat postnatal depression, because we know that mums, well, if they've had a difficult pregnancy, if they've had a difficult birth, they're more at risk of having postnatal depression or problems in the first year. As to long-term sleep effect of sleep deprivation, I think you have to say it heightens your risk of getting depression or anxiety postnatally. I did look at that question. I didn't know whether you meant long term, like when you are 10 years old or later. When you know long term, into how many years hence you've had the child. I mean, what do you think they meant by that question?
I think it's just obviously as an early mother with a young child,
yeah.
you don't tend to sleep as much. What is the long term? Is there a long term effect on the health?
Yeah. I mean, obviously, there's a long-term health effect for a baby whose mother is not functioning well and is depressed and is not picking up the cues from a baby. And where I've worked in perinatal mental health, we've had infant health mental health specialists who are trained to help these mums who have postnatal depression and train them literally to re-interact with their baby and bond. because the maternal bond is so affected. And that can be, well, that is essential, but not all areas have that service. But these mums need a lot of help.
Gestational diabetes is another thing that's been associated in an almost kind of direct linear way with short sleeping. So if I come across any young mother with gestational diabetes or early signs or a family history, I kind of pull out the stops and give them the extra 10 minutes just to really help them on their way, because the environmental factors are so hard, and a lot of it is recruiting help as well.
Yes. Yeah.
All right.
But
So
we are interested in using light therapy to boost antidepressant response if mum needs an antidepressant after birth because she's low, and possibly even to then show that just light therapy alone would be enough, which would obviously mean that problems breastfeeding when you're taking antidepressants would be avoided.
What's the theory behind that? What's the theory behind the light therapy? Because I don't know much about it.
Well, I don't think anybody does really, but they think it does promote serotonin in the brain as the final transmitter pathway. That's an easy thing to say, isn't it? But nobody knows exactly how it works, except it may obviously boost the circadian rhythm, maybe the desynchronized circadian rhythm to be more entrained after childbirth if someone's depressed.
Okay, just got a few more minutes. Who wants to ask the last question? Maybe from from the Slack channel. Rita, you can go. You're muted.
Got one for Dr. Bhatia. Can sleep deprivation trigger vertigo?
I'm just thinking about the mechanics of vertigo. You can get viral labyrinthitises that can trigger vertigo. So whenever I go to an exam and I hear the word could, the answer is probably, the question they're really asking you is what's the mechanism? But I can't claim expertise. I'll offer Dr. Soma or Dr. Hicks if they know better than I.
Oh no, I don't think it's my area of expertise.
No, I don't know actually either. For sure, no, I don't.
I guess if you're very tired, like you said, you're more susceptible potentially to infections that might then lead to labyrinthitis.
And your neural processing is going to be less effective as well. So if you're short slept, you do actually, there's a phenomenon called microsleeps. And there's some quite new evidence that shows that microsleeps don't happen globally. You can actually have focal microsleeps as well. So your whole neurological potential is depleted by short sleeping. And it makes me wonder, you know, if 2/3 of this planet is short slept, how much more lovely can we be to each other if we just slept a little bit better? Do you know what I mean?
Yeah. I wonder if it is actual vertigo or whether it's just sort of disorientation.
Yeah, I think that's probably what it is. Really.
Yeah. How about we go for one last question? Why are some people morning birds and some people night owls? Is there a biological reason for this? Maybe Dr. Hicks.
Oh, it's in the genes. It's in the genes. Well, there's been found, I think it's the University of Exeter in 2019 has used the big genome, I'm sorry, I've lost its name now, but there was a big project looking at everybody's health and epidemiology and measured that there were about 350 genes that make up with us having a light and a lark phenotype to an owl phenotype. And they're discovering more and more of these genes all the time. Well, we don't know why, if that's what the question is, that we're like that. But obviously, those affect how we can have our day and how we can actually function with respect to sleep and alertness.
I would thoroughly recommend everyone read a book called Why We Sleep by Matthew Walker. I think he does touch on that a little bit. but it was released a few years ago. It's very, very popular. It is a very good book. Okay, that makes it 3:30. So unfortunately, no more questions for the experts, but thank you so much for joining us. It's been a fantastic day learning all about sleep. And thank you, Dr. Hicks, for giving your expertise in the past half an hour. I think for now, we are going to have a Q&A with the medical student team about our journey into medical school, because we have quite a lot of viewers who are here on virtual work experience to find out what it's like being a doctor. So feel free to stay if you want to, but if you have to go, that's fine. Thank you again. Thank you so much.
Well done, Vinay. Well organised, and well done, everybody else. Really good.
Thank you.
Well done.
Right.
Well done.
Bye-bye.
Thank you all.
Bye. Bye-bye.
Thank you.
Thank you all.
All right. So all people who are in the Slack, ask as many questions as you want about getting into medical school. We've had quite a few already. So anyone got the first one?
There were some questions about gap years. I'm going to leave that to you guys. I have no clue.
So someone asked, what was the question?
Let's have a look.
Yeah. Okay, so the first question someone asked, Michelle asked, how did you know you wanted to attend the medical school you are now attending? That's a good question to start.
Ooh,
Caitlin, why don't you start?
Yeah, I'll take it if you want.
We can all do it. We can all talk about our medical schools. I think that'd be a good one.
Go on, Caitlin.
This is a very common interview question if you're interviewing at a university. So if you've applied there, know why you've applied there and be prepared to talk about it. The reason why, and HIMSS was actually sort of my first choice, and when I interviewed for it, the reason I was very for it was because of the amount of exposure you had in the first few years in the hospital and in general practice. And a lot of the universities I looked at, you didn't actually get very much general practice experience. And it was something I was really interested in, still am. And that's the main reason why I applied, to be honest. And I also really liked PBL. I didn't really want to sit in lectures all day. I struggle to sit still. So that's why I applied there.
Cool. I'm currently in Plovdiv Medical University. That's in Bulgaria. So I didn't actually know that I wanted to study in Bulgaria necessarily. However, I knew that I really wanted to go into medicine, and it was actually by luck because we saw an ad in the paper to study abroad, and honestly, I just applied, and yeah, it was just serendipity, I guess.
So yeah, with my situation, I didn't get into medicine the first time. So I could have taken a gap year, or the alternative was to do a foundation year. So I studied clinical sciences for a year, and the only university that you could transfer to was Leeds. But to be honest, Leeds is a great university. We start dissections. We have full body dissections in our second year. We start clinical placements from year one, going in once a week, and then gradually building up to 5 days a week in your third year. And not many other universities really give you that exposure. So yeah, highly recommend.
And I went to Bristol. Like Sarah, I didn't get into medical school first time round. But I applied to Bristol twice because I liked it that much. It's a great city. Absolutely love it. And kind of the opposite to Caitlin, I really did not want to go for a PBL school because I didn't like the idea of kind of having to motivate myself to learn things. I didn't like the idea of learning from other students. I wanted people, experts in their field, telling me what they knew. Maybe I'm just lazy, I don't know. But that's basically the main reason why I chose Bristol, because it was for me a very traditional medical setup with 2 years of preclinical medicine in lectures, in labs, in tutorials, and then the next 3 years intensely in the hospitals and in GP practices. And also, I love the city. So that's the main reason why I chose Bristol. And someone asked, what's kind of your biggest interview tip? I would say definitely you need to prepare. It's not the sort of thing that you can just enter and you think you'll be okay. If you do, you basically, I had scripts for certain questions, like why do you want to do medicine? Why did you apply for Bristol? Tell me about an example of a time you showed good leadership skills. I had these scripts that I had memorized, and I had ways in which I would try and make it seem natural. You need to just know it off by heart. As soon it needs to be so natural that it seems as though like you don't even have to think about it. So you need to practice loads. You need to write down scripts, and you need to make sure that you give the best answer, because it's your only opportunity to show off to these medical schools that you are worth being picked.
Yeah, I would definitely agree with you on that, to practice. I like do it in front of someone as well. Like get used to saying it in front of a couple of people at a time. Like I pestered my family, and like the amount of times they heard it, they could probably recite it as well.
Yeah.
But just get comfortable in front of people. If they see that you're at ease, you're happy enough, they're going to feel better. It makes them feel less stressed, because they're seeing a lot of people. And just be open and honest. There obviously are like tips online, but try not to be too sort of rehearsed or too the same as anyone else, because a lot of people will answer the same thing. So it just helps you stand out a little bit more. But like it's okay to be nervous. I was terrified walking in. Like I was shaking all over. You'll be fine. It's not a big a deal as you think it's going to be. They're very lovely people, or at least mine were. You'll be okay.
And make sure you get your personality through. If you're not showing off how unique you are, then you're just going to be a boring candidate. No one wants to pick someone who's boring. Show off how interesting you are.
Yeah, I definitely agree with that. And yeah, as you said, failing to prepare is literally preparing to fail with these interviews. And also universities like Leeds have MMIs. So you have different stations, and for these type of interviews, I think it's a bit more difficult to prepare for. So you do need to know more about like ethics, situational judgment. Leeds actually takes the BMAT, so they will pull out your BMAT essay and ask you about it. So as soon as you do your BMAT, make sure you write about the question that you answered, so that you have something in mind to talk about at your interview as well.
Someone just before we go to the next question, someone has asked, do the interviewers judge you if you're very nervous in the interview?
Mine didn't at all. Like I was so red in the face. I get very nervous and that sort of stuff. I was shaking all over, sweating. I'm sure it was very noticeable, but they didn't care. They're used to it, You're basically still a child. You're like 18. You're in this room full of adults. You're like holding the key to your future kind of thing. They're going to be really lovely. Don't worry about it.
Yeah, definitely. And I feel like the more prepared you are, the more confident you'll come across as well. So that's why it's really important, actually.
Yeah, remember, there's no difference between acting confident and actually being confident. So as long as you show off how confident you are, it's all about deception. It's the art of war. Sorry, Rita, you were going to say something before.
No, I was just saying that in Plovdiv Medical University, we didn't actually have an interview to get into medical school. So we just had an application and that was it. But now they've introduced an entrance exam. So yeah, it's interesting to hear all of your views on interviews.
I feel like we all did quite different interviews, because I didn't have MMIs. I had like PBL.
I did MMIs, and we had a manual dexterity test as well, which was odd. You can't really prepare for that.
A little bit additional. I don't know how it was with your MMIs, but they might ask you a little bit about like what's going on in the world, the health world kind of thing. I got asked, I think, just know, like have a read of the news the day before or something. Have a look at the health section and see what's going on in the world. Wrap your head around it, form a bit of an opinion.
Yes, definitely. Know what's going on in the world.
I remember Leeds actually had that as well, where we had to analyse an article that they gave us and then talk about it. So yeah, it is important. And we had a like role-playing station as well, where you had to calm down a patient. That was very different. I wasn't expecting it. So yeah, you kind of have to be prepared for everything. But you know, like the experiences that you've gained through your work experience should have prepared you for such situations. So you'll be absolutely fine.
Yeah, like Sarah said, trust your gut. They're going to want to know who you are. Just trust your gut and go with that.
Yeah.
And with every question, always give yourself 3 seconds before you answer. Even if you know exactly what you're going to say, you need to sort of show off that you're thinking about it. And if you do come across a question that you're completely stumped by, think about it in a really logical and structure your answer well. It's often the case in medicine that people don't actually really care what answer they give. As long as you give an answer with a structure, people are happy because it shows that you're logically thinking things through. So think about it in terms of pros and cons, disadvantages or advantages, why, where, how, you know, however you want to structure it. As long as you have that, it'll help.
Next one.
Question. I would like to know about the application process experience as a graduate student aspiring to enter medicine. How is it different entering medicine as a later stage compared to those A levels? Rita, do you want to?
Ooh, well, this is quite interesting because I went into medicine maybe 2 years after graduating. And so I graduated from the University of Lincoln studying human nutrition. And then I worked in the food industry for 2 years. And then I went into medicine quite late, around 24. I guess it's not too late. It's never too late. So if you're older, younger, and medicine is what you want to do, then definitely go for it, because I honestly thought that I'd be one of the oldest people going into medicine. But once I got here, almost everyone was the same age or older. And it was brilliant because everyone came from a different background, but we all really gelled, and it was brilliant being able to share ideas with people that don't come from the same background, people that aren't the same age, people that come from different parts of the world. And so it was really eye-opening, to be honest, and it's definitely a decision that I don't regret.
Great.
Yeah, I feel like that's a really good point, because when you go, there was quite a few grads at Hull York, at least in my year. Like, it doesn't really make that much of a difference. Like, they tend to know more. They're a lot more relaxed in themselves in consultations because they're a bit older. They have a bit more confidence. But like, you all have different experiences anyway, no matter what age you are. So you're going to learn from each other no matter what.
Yeah, definitely. I feel like in our year, you can definitely point out the grads, especially if they've done science degrees like pharmacology. Obviously, they're going to know everything, or like neuroscience. They all ace those modules, but you end up befriending everyone. But then there are grad-only courses as well. I think Warwick. So if you prefer to just be with grads, then that's a university to go for.
Also at my university, because I was a graduate, I was able to exempt some examinations because I had already done them previously. So that was definitely
Nice.
Better in terms of stress.
Someone has asked about gap year students. What's important to know for when reapplying? I would say that you are you're a solid bet because you have got your grades, and if you're applying for the second time round, it shows that you're a little bit more serious about becoming a doctor than a lot of other people. I would kind of show off how much you've grown and what you've achieved in a year, because there's actually a lot you can do once you don't have the pressure of exams, and just kind of do things that you wouldn't normally do. You don't necessarily have to do medical things all the time. It's probably good to keep maybe one medically-ish thing ticking away in the background, but just do stuff that you enjoy, stuff that you'll learn a lot from, that you get loads of different skills, and it'll help a huge amount. I think the main thing about these interviews is that they're not looking for someone who's obsessed about medicine and who has all the correct skills to become a doctor, because you just don't. You're 18 years old, you don't know anything. So they're looking for people who are humble. They're looking for people who know what it takes to become a good doctor and can start to learn that sort of stuff.
Yeah, definitely. I had a couple of friends who took gap years as well. And, you know, they worked for half the time, traveled, because through all of these activities, you also gain skills that you need in medicine, like communication, independence, leadership, teamwork, and so on. So it's all about gaining those transferable skills, really.
Hmm.
And like Vinay said, reapplying, like obviously I didn't take a gap year, I don't know, but in speaking to one of the deans in Queen's, which is like the only medical school currently in Belfast, they actually quite like grads and gap year students because it shows that they're committed, and they quite like that whenever they are looking through the applications.
What tips do you have for writing your personal statement? How would you demonstrate your passion for medicine in your personal statement? Oh, memories. Go on, Kate.
I'm gonna boil out. That was I hate writing. I hated writing a personal statement because it's so hard to make yourself come across.
Yeah.
Yeah.
Yeah. So like the structure of your personal statement is very important. Like especially the first paragraph. Shameless plug, I have a YouTube channel and I've actually like made a video on how to write your personal statement. I will leave it below, like in the Slack channel, so you can have a watch of that. But yeah, the introduction to your personal statement is really important. So like that's the part that you should like really tell them why you want to do medicine. Like insert a personal anecdote, just make it very individualized, because at the end of the day the admissions officers are reading thousands of personal statements, so tell them what makes you different.
And don't be shy about showing off. That's what it's there for. So, you know, use all of your strengths to your advantage, really.
Yeah, you might feel uncomfortable to start sort of like, I don't know, basically flexing, but that's what you're writing it for, is to be like, I'm great, this is why you want me there. Like not the other way around.
I would make sure that every single sentence, especially in the first paragraph, actually means something. And when it comes to I think the first, like Sarah said, the first paragraph is the most important paragraph. I would probably advise you not to write it first. Write it after you reflected about your work experience, your volunteering work, your extracurriculars. Only then should you start thinking about, actually, why do I want to do this? And I think I'd hit 3 points. It's kind of why you and medicine. So think about why you want to do it, and don't just say like, oh, I love science and I want to help people. That's not a good answer. Think about genuinely why you want to do it, and inject you into it. So what is it about your personality? What is it about your kind of qualities that would make you a good doctor, that would make someone think, you know what, you should actually be a doctor? And specifically, you need to answer the question, why do you want to be a doctor and not any other healthcare professional? And that applies to nurses, to pharmacists, to anyone in this particular field. You need to specifically look at what is the role of the doctor. And there was a document released by the British Medical Association on what is the role of a doctor. That is a fantastic read for anyone applying for medicine, because it basically specifies what makes a doctor unique, what makes the role of a doctor unique compared to everyone else on the rest of the team. And you need to identify those particular roles and attributes that makes you specifically good for that job. It's a really important part of the personal statement, so I'd spend most of your time on that.
I feel like that ties quite well in with another question here. It says, if you had a personal experience that helped guide you towards medicine, should you include this in personal statement / interview? Absolutely. Yeah, I did with mine. I talked about mine, and it was something that came up in the interview as well, because they'd read it and they were like, can you expand more on it? And if you feel comfortable talking about it, do it, because it's honest, it shows who you are, and it also shows a bit of commitment that you've actually thought this through and you're very introspective.
Yeah, they want people who can reflect on their experiences, and they don't want to have the same conversation over and over again. Would you rather have a conversation with someone who says, oh yeah, I really like science and I kind of want to help someone, versus someone who talks about their experiences in hospital and the unique struggles that they had, and how they really saw how noble the profession was and how they really admired the doctor? That's a much more personal story. It's a lot more to do with who the person is. So if you have an anecdote, share it.
Is there anything you did in the summer before uni that helped you with the course?
Ooh, I can go for this one. So after university and after working for a year, I actually went to Thailand to work in a state hospital. And I did that, and I went traveling on my own for the first time. And it was great because we got to see so many surgeries. I stayed there for a week with people all across the world, from America to Canada. It was brilliant. And if you can get onto a project where you can volunteer or shadow in a different country, I would definitely recommend it, because it's really eye-opening and it really makes you appreciate the NHS, to be honest. And also, so I got to see things like cataract surgeries, deliveries and births, and yeah, it was just a brilliant experience. So, and you get to do a bit of traveling, so there's so it's all good.
What did the rest of you do the summer before?
I literally was exhausted after A levels, and by that point you kind of like knew where you were going. So I just like traveled and relaxed, and to be honest, like, you do need to do that before starting university again, and I highly recommend it.
I did the same as Sarah, because I'd been volunteering throughout school. Yeah. So then I said, a month before uni, I'm going to say I'm leaving. This is sort of my last few days volunteering here. And then I went traveling with some friends, and it was great. I felt very well rested, got very sunburnt. It was great.
Yeah, I did a similar thing. I went interrailing, and I spent like a month just like drinking great wine and having some really great food. Yeah, so I would recommend you do that before you go to medical school. Have some good times. Have we got any more questions?
Something here about, I didn't take the BMAT, but tips and preparation for UKCAT and BMAT.
Sorry, you did the BMAT, didn't you?
Yeah, I did both. So biggest tip is timing, because I can't multitask. I don't know if any of you guys can, but I couldn't. So what I did, especially the second time I was applying to medicine, is book my UKCAT quite early. It's actually called the UCAT now. Yeah, so book your UCAT earlier, so you get it done maybe like by the end of August. And then that leaves you with plenty of time to start preparing for your BMAT and, finalize your personal statement and so on. And the two tests are quite different. So I personally much preferred the BMAT. So if you're like more science driven, you would prefer it, because there's definitely a way of preparing for it, and they have a specification of topics that you can go through and so on. So yeah, I would say it's all about the timing with that. And leave about a month or so to prepare for both these exams.
I found with the UKCAT, you shouldn't give yourself too much time, because it's a really, really boring test. So if you kind of give yourself like 2 weeks and just study really intensely for it, because every time I did the UKCAT, and I did it twice, and I did really badly both times, I felt as though you're like getting better, and then you kind of hit a peak, and then you kind of go down a little bit. So you want to hit the peak. You don't want to get bored and start to flag. So don't give yourself too much time. Study intensely for it, and yeah, don't try not to get too bored for it, because it's not a fun exam. I did do the BMAT the first time round. The BMAT website has got all the past papers. That is an incredible resource. I did particularly quite well in the essay section, which I know a lot of people struggle on. I would say read as much as possible. So read about the history of science, the history of medicine, read about the philosophy of medicine, read some ethics textbooks. There are these books, A Very Short Introduction To. Read those. They're really good topics for you to just get some background knowledge and kind of just inject interesting anecdotes and interesting facts into your argument, and that just basically builds it up a lot better. It helps a lot if you've done humanities A levels, and if you did well at humanities GCSEs. But that's how I would prepare for the BMAT if the essay still exists.
Yeah, definitely. Do as many questions as possible. There are so many free resources out there now as well, like PassMed has free resources, Medify is excellent. And if you run out of the BMAT papers, Cambridge also has the TSA papers. I think it's for like natural.
That's right.
Is that right?
Yeah.
Very similar to BMAT. So, you know, if you actually manage to go through all the past papers, you can start doing TSA papers as well.
Think laterally when it comes to the essay. They're looking for people who can think laterally, not just in one direction.
Yeah, I only did the UCAT, just practice. There's stuff out there, just practice and get used to reading or skimming things and just moving quickly.
I did the GAMSAT, which was the graduate entry one, and similar tips, to be honest. But for the GAMSAT, I think you should take a bit more time, make sure you structure your answers properly, and really go through each section to make sure that you understand all of the components. So.
The last question is: did any of you do an EPQ, and did you feel like doing well in it could help into compensating not getting straight A's in GCSEs? Anyone know anything?
Yeah, I did EPQ.
I did EPQ.
I actually don't know what it is. What is it,
Extended
guys?
project qualification.
Yeah.
Right, okay.
What did you EPQ on, Sarah? Go on, share with.
The Nazi human experiments.
Oh, right.
Because we get a lot of our evidence-based medicine from the experiments that they proposed back in the days, and I basically delved into the ethics of that. So it was like super interesting. I enjoyed doing it, but it did take up a lot of time. And it's more useful for students that are doing different courses where their UCAS points matter. Whereas with us, for medicine, you kind of just need 3 A's. But again, it was something quite helpful to talk about in my personal statement and interview, kind of differentiates you. And it does give you the necessary research skills and so on that you really do need at university. So yeah, I would say it's definitely worthwhile. So
I think there are two things I want to say. Firstly, you really important take-home message. You need to apply to medical schools which you think will take you. The reason I didn't get into medical school the first time around is because I applied to medical schools which, in retrospect, I knew would just not take me. I applied to UKCAT heavy universities and I had a really bad UKCAT score. But I also had a great personal statement. I did not too badly on the BMAT, and I was all right at the interviews. But I didn't apply to those sorts of medical schools who weighted that a lot heavier. So look at your strengths of your application, look at your weaknesses, and maximize your strengths when it comes to this application, because there's no point applying to places that will not take you because of the way of which they select their applicants. And secondly, just to reiterate what Sarah said about EPQ, EPQ is a great thing to do. It's really interesting. I did mine. I'm really into history of medicine, so I did mine on the idea of professionalism in medicine, and I looked specifically at the Victorian era, and it allowed me to learn a lot about research skills. I actually looked into BMJ archives, so those sorts of research skills which you start to develop a lot more at a medical school, I was sort of a little bit ahead of that. So I would 100% recommend you do an EPQ. I think it makes you a lot more interesting as well. But in terms of like selecting medical school, select one that will choose you.
Yeah, I would definitely agree with that. I made a table of like what the universities were looking for and just scored out the ones that I thought weren't going to take me.
Yeah.
And then from there was like, what is important to me from this list? And then that's how I picked the university I wanted to go to. But like in terms of, because this person said, should you do it to compensate for not getting straight A's in GCSEs? I didn't get straight A's. I got 2 B's, I think. I can't really remember, it was so long ago. I know I definitely got some B's, and it's not that important for certain universities. So don't worry about it too much, because after I got my GCSEs, I was like, oh no, I can't do medicine. Oh no, I'm going to have to retake it. Don't stress about it. It's going to be fine.
Yeah, it definitely goes back to the whole thing of, applying to universities that suit your capabilities. And like obviously universities like Oxbridge do place more emphasis on GCSEs, whereas others like Leeds, I think they only want Bs or Cs in English and maths. So
yeah, it's the same as Hull York.
your strengths.
Rita, did you have a question?
Cool. Yeah, I've just got one question. I got ABB. I'm predicted ABB for A levels. Should I still apply for medicine? So I think Caitlin, you kind of answered that. So the answer.
Yeah, well, that was for GCSE. I don't really know so much about A levels, but a lot of universities now, I know Hull York definitely do, just have a look at widening participation schemes. But apart from that, I'm not actually quite sure.
Some universities might not look at your predicted grades as well. Some universities might ignore it. So again, depends on the university. They all have different selection processes. Look not just at the admission criteria. Admission criteria means they will not chuck away your application at the first step. Look for the selection criteria. That's how they take those that actually they will look at and then further look into the application. So that it's some people look at the wrong thing when they apply. So look for the selection process on their website. That's more important than just the admission criteria.
Yeah, and also on the day, although those are your predicted grades, say on the day you do get ABB, don't get too disheartened. You can either retake them or take some time out, figure out what you want to do, whether you want to do a degree and come back, or whether you want to take a year out and reapply the next year with widening participation or something like that. It all seems quite scary right now. Just don't let it affect you too much.
It's not a race.
No, not at all. And some of the best doctors are the ones that have come into it later in life because they really know they want to be there.
Definitely. Yeah, I was in that very same position. So I had an offer, but I ended up getting a B in chemistry. So I kind of just found clinical sciences through clearing and then entered medicine through that. But again, as Caitlin said, you can just take a gap year, but there are only specific universities that take retake students. So do make sure to research that as well.
All right, I make it 4. So that is the end of the sleep webinar. Thank you so much for joining and hearing about us all talk about sleep and our fantastic external speakers. It was all very interactive and it was all really interesting and thought-provoking. That's everything from me, everything from all of us. Have a good evening and a nice sleep. Way to end it.
Thank you for tuning in. If you have any questions, DM us. We're all on Twitter and Instagram.
And on the Slack.
Always happy to help. If you have personal statements you want me to read over, happy to do that as well.
Yeah.
Yeah, you guys are as well. Yeah, there you go. 4 people.
Any questions, just reach out either on our private social medias or on the Medic Sleep because we'll keep those running.
Yeah.
Oh yeah, Medic Sleep is going to continue.
Yeah, so it's not just
become
today.
Huge. Like everyone will know about it in a year's time.
And also check out the Persian Medic on TikTok.
Oh yeah. All right. Thank you very much.
All right.
Thanks, guys. Bye.
Have a great day, guys. Bye.
Oh, you left.